Hi, everyone. I'd like to welcome you to the Canadian Activity-Based Therapy Expo. We just wanted to get started right on time because we have a lot of things to do today. So, yeah, we'll start with a few introductions. Um, so first, I am Hope Jervis-Rademeyer, co-lead of the ABT Community of Practice. I'll be one of your moderators today, along with Chris Walden, unfortunately, is dealing with the ongoing situation, but she has contributed highly to the presentation today, so we want to thank her. She's another co-lead of the ABT COP, and also Anita Kaiser, our other co-lead of the ABT COP. I'd also like to introduce Samantha C., who is our ABT COP coordinator. Thank you, Sam, for all your work behind the scenes today, too. Now, I'd like to start with a land acknowledgement to open the meeting. We would like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the lands which we call home. We do this to reaffirm our commitment and responsibility to improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join us in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. Thank you. So we have sent this out prior to the meeting, but this is a brief agenda of today. So we'll start with the welcome and introduction. Braden will give the opening remarks. Then we'll have Dr. Inez Bosch-Parada giving the keynote, followed by Dr. Jose Zarifa, Dr. Dorothy Bartolome, followed by a short 5 to 10-minute break. Then we'll hear from Dr. Matija Milosevic, Dr. Damien Manzone, Dr. Sujata Sinha, followed by Dr. Krista Musselman and Dr. Anita Kaiser. And then we will have a panel facilitated by Anita. And then I'll be providing some closing remarks along with Sam C. A bit of housekeeping before we start the expo. This meeting will be recorded and the link will be shared with all registrants. Please ensure that your microphones are muted during the presentations and use the raised hand function during question periods. For live subtitles in French, you can turn on Zoom's automated translated captioning feature. And for instructions, you can refer to the link that's going to be placed in the meeting chat. There it is right now. Please use the meeting chat for any additional questions or comments you might have during the presentations. And if we don't get to them during the presentations, we can always send them to the speakers to answer, and then we'll get back to you with those. So the ABT definition, according to our ABT COP, this is the definition that we use. So ABT is therapeutic activities that involve repetitive neuromuscular activation below the level of spinal injury, achieved through intensive task-specific movement practice. It promotes neural recovery and physical fitness and decreases the risk of secondary complications. And this is just a photograph of everyone who attended the initial ABT summit way back in 2019. Now, what is the ABT community of practice? The community of practice is meant to bring together individuals with a common interest in ABT to work collaboratively to expedite the advancement of the Canadian ABT priorities. It means to optimize the quality of ABT and access for people living with spinal cord injury in Canada. And this is just a brief overview of the ABT Community of Practice membership. Currently, we have 107 registered members. And if you look at membership by interest group, we have on the right there, the light blue part of the circle, we have 41% of our members are health professionals, 25% are researchers, 13% are students, 7% are business owners, managers, or administrators. Then we have people with lived experience and caretakers representing 10%, industry 1%, and funder represented by 1%. Membership by location. We were looking at this just the other day, and I was thinking that it really almost reflects the population across our different provinces, and of course the USA and international is included there as well. So quite a few members across the provinces in Canada. So that shows how diverse our membership is, and strongly supported if you would look at the percentages compared to population, I think. And we've had a lot of key outputs, so congratulations to everyone. We've had the Spinal Moves podcast updates this past year, and the video series, we've put out 2 episodes out of 4 likely coming out. We've had ABT information cards. We have had 22 publications, 4 conference symposiums, 23 invited talks or presentations, and 4 grants for COP related projects. And the images that you see here are just outputs within the last year. So a lot of good work. Congratulations, everyone. Next, I'd just like to go through our current COP priorities as of 2023. This is the last time we revisited them. The first is to create learning resources on ABT for clinicians and people living with SCI. Number 2 is to track and evaluate participation in ABT. Then implement strategies to facilitate dialogue between hospital and community groups. Number 4, create and implement a standardized approach to evaluating ABT outcomes. Number 5, develop an initial best practice guideline for ABT after spinal cord injury. 6, improve engagement in ABT activities across key interest groups throughout the continuum of care. And number 7, to identify and implement strategies to improve access to ABT and related technologies. And now we have a number of current COP projects, and they're related to the different priorities. Priority number 3 that I just discussed is actually done through having the COP itself, so you won't see number 3 on this list. These are our different project groups. So we have number 1, to develop an ABT best practice guideline. Number 2, to develop a freely accessible ABT education course and ABT video series. 3, develop a community ABT outcome measures toolkit. 4, develop a resource to facilitate finding clinics, practitioners providing ABT in Canada. Next, develop an ABT tracking tool and app to collect it and be used for outcome measure reliability and usability testing. And then to continue to develop a COP social media platform. And you'll see the priorities that align with each of these. And you'll see the leaders of each group or co-leads on the right-hand side. And if you are interested in joining any of these groups, we're always welcoming new members. So please email the ABT COP. You'll get the information at the end, and then they'll pass on the information to the leads and co-leads. And next, I would like to draw your attention. This is one of the outputs of one of the groups. So the ABT Best Practice Guideline Development Delphi Survey. We do really want to hear from you. We need participants to understand how we can best develop an initial best practice guideline for ABT after spinal cord injury. So if you'd like to scan the QR code and participate, feel free to do that now. Also, we're happy to send out this information if you contact us at the end as well. You can also, contact Janelle Unger, who is the PI on this. Next, mapping clinics that provide ABT. Again, this is another project, and it targets priorities 6 and 7, so to improve engagement in ABT activities across stakeholder groups throughout the continuum of care, and explore the access to ABT and related technologies. So Do you deliver ABT at your clinic or practice? If you do, please scan the QR code and help us to map your clinic or practice within the ABT clinic map across Canada. And I believe Sam has put the link for the best practice guidelines, and she'll also put the link for the study in the chat if it's available. Okay. And now I would like to introduce our first speaker. Okay. Braden Pettinger is 30 years old and lives in Regina, Saskatchewan. He sustained a C5 spinal cord injury in 2015 after crashing headfirst into the boards while playing hockey in his home province of Manitoba. Shortly after his injury, Braden moved to Regina to do ABT at First Steps Wellness Center. Over the years, he has become increasingly involved in the disability community in Regina, regularly attending events hosted by the Saskatchewan Wheelchair Sports Association, Realm Foundation, and First Steps Wellness Center. Braden is also a member of the City of Regina's Disability Reference Group, which advises on recreation projects and initiatives, as well as the Adapted Sport and Recreation Grant Adjudication Committee. Currently, Braden works for the Spinal Cord Injury Saskatchewan as a client support specialist, where he supports and is an active resource for individuals with physical disabilities. He previously worked for the Saskatchewan Wheelchair Sports Association and played a role in restarting the Regina Wheelchair Rugby Club following COVID-19. Braden is also completing a psychology degree on a part-time basis. And without further ado, I'll introduce Braden and he'll discuss my ABT journey, progress, purpose, and possibility. Is Braden here?
Yeah.
Oh, go ahead, Braden. Sorry.
All right, good morning, everyone. I'm going to start things off here this morning. I'm just going to talk briefly about my story and my experience with ABT. So my ABT journey started in 2015. I had just turned 20 years old. I was playing my final year of junior hockey. I had just been traded from the last place team in the league to the first place team. And I was really excited about joining a new team and having a good shot at winning a championship that year. So my first game with my new team was in Winnipeg, Manitoba. And with about a minute left in that game, I crashed headfirst into the boards, broke my C5 vertebrae, and had a spinal cord injury at that level. So from there, I spent about 7 months in the rehab hospital in Winnipeg. I had a great physio team. I was lucky to get 2 hours of physio 5 days a week, an hour of OT every day, and I was busy, and it was good overall. Then I started hearing about places like Project Walk and later on First Steps Wellness Center. And it was this new type of therapy that, it sounded completely different from anything I'd heard before. And I was hearing about people having good results and people regaining function below their level of injury, which sounded crazy to me at the time. It was something that I had never been told about during rehab. It didn't really seem to be known by anyone when I was in rehab at the time. Next slide. So with First Steps Wellness Center being located about 3.5 hours from home, it was a logical choice. Me and my parents drove out to Regina. I dove right in. I started doing therapy 5 days a week. And as time went on, I began to learn more about ABT and this whole idea about being able to regain function below the injury. It was invigorating. It gave me motivation, it gave me hope, and it gave me something to work toward. And I began to make progress. I started seeing small weekly and monthly wins. And over time, I learned the importance of celebrating these small wins. Progress wasn't dramatic, but it was just that it was progress, and that meant everything to me at the time. Over the years, this small continual progress led to big, meaningful changes in my daily life. I went from essentially needing 24-hour care when I left rehab to being almost completely independent. I gained the ability to do things like transfers, get in and out of bed myself, get dressed independently, cook for myself, and eventually drive myself. Next slide. As time went on, I began to realize that First Steps wasn't just therapy, it was a community. You know, seeing the same people on a daily basis, the therapists, but also people with similar injuries, people who had been through similar experiences. We could talk about the challenges that we faced on a daily basis, and more importantly, the solutions to these challenges. And I began to realize that emotional healing was just as important as physical healing. As the physical progress happened, my confidence slowly returned. I began to regain identity after injury, which was something I never understood before my injury. You know, people would talk about losing their identity. I didn't know what that meant until after my injury, when I lost a lot of those things that made up my identity pre-injury that I didn't even realize. No, as my confidence returned, I slowly began to put myself out there socially again. I started getting more involved in the community, and I got involved in wheelchair rugby, which introduced me to a whole new community of amazing people, gave me opportunities to travel to places that I never would have went before. And it's one of my favorite things to do today. So early on after my injury, it was my whole purpose was to fix my body, to get my body working again. And that focus helped push me physically, but real purpose took longer. You know, learning to enjoy life again, finding meaning beyond just physical recovery. And all that kind of led me to what I get to do today with Spinal Cord Injury Saskatchewan. I get to use my lived experience to support others, help people navigate challenges after SCI. And that's been very rewarding for me. It's something that I very much enjoy. Next slide. So just to wrap up here today, I just want to talk about what's possible when it comes to ABT, why the future of ABT matters. You know, ABT gave me the opportunity to change my life for the better. And that's why I think that it's so important to increase access to ABT now and in the future. You know, whether it's financial barriers, geographic barriers, systemic barriers, you know, getting ABT fully integrated into the acute care phase after SCI. I think that's also important, you know, even the importance of research, growth, continuing to refine therapy approaches, learning more about timing, intensity, modalities of ABT, making ABT as effective as possible. This is why I have such huge appreciation for all the researchers, the clinicians, the doctors, the advocates of ABT, all working to advance ABT, and more specifically, the ABT community of practice that Hope just mentioned. All these amazing people putting in countless hours, all the work that they put in to advance ABT. I think that's so important. You know, all that work being done now, it'll impact people with new injuries in the future, people living with SCI today. And I just truly believe that ABT across the whole care continuum has the power to change outcomes and ultimately change lives. So yeah, hope you guys enjoy the rest of the expo today. Thanks for listening.
Thanks so much, Braden. And we didn't really have a question period for you, but I'm wondering if I could just ask you if you have some advice for someone who is just starting ABT, what advice would that be? Putting you on the spot.
No, it's all good. Yeah, I think just dive right in. You're going to be hesitant at first to try a lot of these new things, to try a lot of the new positions that you're going to get put in ABT, and it's going to be a little bit intimidating at first, but dive right in, put everything you have into it. Like I mentioned in my talk, there's going to be a social aspect to it as well that you're going to gain from. But yeah, you're going to gain physically, you're going to gain socially, and it's all going to be worth it if you really commit to it.
Well, thanks again, Braden, for speaking to us. I think it's just a remarkable journey going from like almost 24-hour care to wheelchair rugby is pretty rough. I still have to see it. I'm going to catch the next game in Saskatchewan, I promise. Um, yeah, so I'm just going to, uh, is it okay, Braden, if I put your email in the chat if people want to contact you?
Yeah, for sure.
Okay, so I'll do that, and then I'm going to pass it off to Anita to introduce our next guest.
Thanks, Hope. So I have the privilege of introducing our first keynote speaker for today. Dr. Inez Bursch-Parada is graduated physiotherapist since 1989. She went on to complete a Bachelor of Education Science in 2008, a Master of Science in Neurorehabilitation Research at the Danube University of Krems in Austria in 2012, and a PhD at the University of Gothenburg in Sweden in 2019. Her PhD project investigated the upper and lower motor neuron lesions in tetraplegia, diagnostic and therapeutic implications of electrical stimulation. From 2014 to 2017, she worked as a therapy instructor for physio and occupational therapists in a team of 120 therapists and was responsible for the advancement of functional electrical stimulation, robotics, and the evidence of therapeutical treatments. In January 2018, the Swiss Paraplegic Center established the International FES Center for Treatment and Education. She conducts international and national courses and lectures to enlarge and spread the knowledge and the application of electrical stimulation in neurorehabilitation. As a member of the extended board of IFESS, Dr. Inez Bursch provides webinars to share clinical practice and scientific evidence with clinicians, therapists, engineers, scientists, and end users. As a leader of this department, she focuses her work on the combination of patients' treatment and research in this field to transfer the results from clinical trials and technical research, as well as new technologies, into daily rehabilitation. She is focusing her research on 3 health priorities and rehabilitation for spinal cord injuries: improvement of hand function, improvement of bowel function, and secure skin integrity to prevent pressure injuries. Welcome, Dr. Inez Bursch-Parada.
So, thank you for the nice introduction. I want directly to share my screen. I feel very honored to be a keynote speaker in your group. So I hope that I can give a little insight into my work. And do you see my screen? Everything?
Yes, we
Is
see
it
your screen.
perfect? So my talk will be about using electrical stimulation in daily life to promote independence, or in other words, from evidence to independence, bring this topic. And I want first only to show you, as already mentioned previously, that in our department, we are focusing on 3 main aspects: on treatment, on research, and education, because the philosophy is that all 3 topics together can bring us steps further in treatment and bring directly benefits to our clients using electrical stimulation in an independent way at home to increase their independence and their quality of life. Therefore, we see very often during our treatments problems or aspects that we want to look a little bit deeper into detail. Therefore, a research question comes up. And so we conduct our research based on our clients' needs and evaluate this and bring it back to the community, to other therapists, clinicians, nationally and internationally, to share our knowledge and to get the exchange with other people, how their experience on different topics is. So that's basically what we are doing. And I thought I have a little bit to look about independence. I have first here to make it to see my slides. So what does independence mean in this current context? So in the tradition of Immanuel Kant, autonomy means being able to act according to one's own rational decisions rather than external pressure. So, in other words, the capacity to decide, not necessarily to execute every action physically, but having control over how life is lived. So, in the context of electrical stimulation or technology, what does this mean? So we have a lot of choices we can take. That's a choice over care and assistance, participation in society, ability to pursue personal meaningful roles. But in this context, that's the access to environments and technology. And that is something very important, that everybody has access to it and has the knowledge of new techniques or new developments or different therapy methods to be able to participate. So therefore, in the International Fest Center, we first built up our vision and mission. And that was quite meaningful for us because we wanted to improve body functions, body structure, and activity, including capacity as well as performance, by applying all kinds of and modalities of electrical stimulation. And therefore, the team agreed with the mission that we are continuously developing, investigating, and evaluating new treatment strategies for electrical stimulation with the aim to enhance body function of people with spinal cord injury, as well as central and peripheral nervous system, affecting relating diseases. The focus lies, as you already heard, actually on upper extremity function, skin integrity, bowel management, and cardiovascular health. So the team of the International Fest Center is convinced of the effectiveness, efficiency, and sustainability of electrical stimulation and committed to transferring the results of research in daily treatment as well as sharing the newly gained knowledge in professional circles. If you work in a team and you want to develop a technology or a technique, that is crucial that all members of your team have the same idea and the same philosophy, and that they commit to do so. So later I will bring up some examples, but only to let you know how many treatments we do over a year and how we could, since the opening of the International Fest Center, we could develop the treatment and the acceptance of treatment in clinic and in the community-based society in Switzerland. So we started, as you see, with some treatments in 2018. That was a year, 100 73 treatments, and we ended up now with nearly 2,000. And you see, we had a little decrease because we dedicated more in inpatient treatments, and so there was a shift in. But each year we have about 150 new consultations coming in, and our inpatient treatments increased enormously. So, yes, we have evidence. A lot of people are struggling with evidence and electrical stimulation still, but there is evidence. And you can read thousands of good performed studies that support the evidence. And today I want to bring up a little bit closer some examples because I can't talk about everything. I want to have a look into spasticity, bowel function, and function, support of function in detail in terms of walking function. Good. If you look to the overall application methods and ways how electrical stimulation can be administered in an outpatient and inpatient service. So everything can be administered if you have the tools and the environment and the equipment in an inpatient setting. Here you see our differences. So everything, also the yellow ones, outlined with outpatient treatment can be used as inpatient treatment. We have only the lilac ones, weaning and prevention of subluxation, that is mainly in our service in an inpatient program. But all the others, neuromodulation, airway management, reduction of spasticity, all forms, support and replacement of function, cardiovascular health, motor learning, strengthening, bowel management, prevention of pressure injuries, and pain management can be conducted in an outpatient service or can be conducted at home in a self responsible treatment by our clients, supported via telemedicine from our team. And to make this run, there is a very crucial point. It has to be accessible and somehow easy for everybody. And so we have this flowchart that we have a request from a client or from a caregiver or from interested people who want to come in our service, and you can do it either via prescription, via email, or via telephone call directly. You get an appointment, and that's depending of your own background, from about 60 to 90 minutes. And then after this evaluation, what kind of modality of electrical stimulation of your individual need is needed, a treatment recommendation is set up, and we write a report either to therapists, clinicians, and then we have a close contact with the FES Center, with therapists and clinicians, conducting in another inpatient service our recommended treatment, or we send people home with a device that can either be bought or be rented, and then they come on regular basis as follow-ups to us back into the FES Center to get modification of the treatment, of the parameters, or changes that can be made for them in the usage of the electrical stimulation in a home-based setting. And we have a lifelong follow-up, because as long as the stimulation is actual and will be conducted, they will be in a recall and follow-up system in our center. So let's go to the next slide. So therefore we have sometimes in our service a clinical evaluation and a supported phase of electrical stimulation usage. Then we have this intermediate phase where all our clients, being previously an inpatient, now a center, they have a learning phase where they can try out how to conduct this treatment at home, and then they are sent home with the equipment and they can use it independently in a home-based therapy, coming back, as I said previously, to a follow-up. If the client has never been in our inpatient service, you have seen it previously, then you can conduct the International Affairs Center, or you can contact the International Affairs Center directly to get access to those treatments. So accessibility is a quite important topic to enable the treatment and the usage. So yes, you need a certain equipment, and the equipment for home-based usage and mainly clinic usage differs a lot. And that's based off usability, and it's based off costs, of course. So you see here on the pictures and the devices I'm using, but that is basically not important because the name of the device is one thing. The most important thing is that you have clinicians and therapists knowing what is coming out of the device, and if the device is for a single individual meaningful for the problem the single individual has. So, therefore, I want to give now, with all the confusing introductions, how it is set up, some examples how it may work. And I want to start with walking. So, walking. There are so many devices on the market enabling walking activities. So, and which device fits best is the main question for every client. So we have, you surely have heard by name all the devices, the Phasio walk system, the Bioness, InSido, Oddstock foot drop system, the MyGate, InnoStep, 2-channel stimulators with switches, so, and a lot of more that I can't name. If you're lucky, and I'm lucky in this case, I have access to all the devices that my clients came in and can try out the best for their needs. And this is quite important because if you come and want to have a walking system, it is not that you can put it on and then it will work. You will walk and it will work. You have to be trained before that for long term, the usage of this system is beneficial. And we set up for this a little flow chart where you can see how we do. So first of all, a lot of people think with a low motor neuron injury that they can use those systems. And this is not the case. All foot drop systems are exclusively made for upper motor neuron lesions. So you must have some reflex activity to use those systems. And first we test this, and we are quite honest, if we see partial or complete denervation, we don't advise those devices. If the device is, in contrast, useful, we begin with a training phase before we get the final device home. And this test phase is in between 12 to 16 weeks. And after this training phase, we do a evaluation of the muscular and functional situation. And if the training phase was not long enough, we extend this training phase. And if this phase has finished, then we do a final test for the final device. And then we give the final device home for time to use before the decision is either to buy the device or to get into a rental system that you finally get the device as a device for your own. So it's a long phase, and in this phase where the system is at home, we ask to come back our clients for regular checks every 4 weeks to see their activity and their training status. If the distance, in Switzerland, the distance is not so long as it is in your country, but if the distance, however, is too long for a client, then we provide also telemedicine consultations to see if we can set up. And with new systems that are cloud-based, it's easy to modify parameters. Okay, so how does a test phase looks like? So this is a client of us, an incomplete tetraplegic patient. We look how the gait is without a device, where the problems are. We define,
Bis zum Stuhl und dann
then
wendest
we
du.
look how the device is, how the an AFO would work, and how the satisfaction is with an AFO. And then we have a look how the satisfaction is with an electrostimulation-based system. And we let our clients compare the usage, because we have to have in mind, not for everybody technology is feasible and easy to handle. Sometimes an AFO solves the problem. But in this case, this gentleman decided, no, I feel better with this electrical stimulation-based system. We go to the next. So this is an example where you get a device home, but not always giving independence for home at working means that you have a device at home. Sometimes you set up a treatment schedule to see if over time, by doing neuromodulation and motor learning activities, you can increase independence in walking activities home. And I want to give you a short example here. Here's an incomplete paraplegia, person with an incomplete paraplegia since 2.5 years, T9, AISC. So, and the clinical appearance is quite weird. He has an upper motor neuron lesion in his quads, and he has a lower motor neuron lesion in the glutes and the tip, so a mixed lesion. And he came to us being informed on an official information day, and he asked about electrical stimulation, previously made in his prior rehabilitation. And he was not even informed about this. So he decided to come to us to use a robotic system by doing electrical stimulation. And as he was a hiking person previously in Switzerland, we decided, okay, we put his videos on where he used to walk previously to motivate and to get another access to his walking activities. And for the lower motor neuron lesion, we do sometimes also fancy things. We use long pulse stimulation, as you see in the little video there, on a leg press, the other way around. And he is stimulating his glutes by extending his legs at the same time. And after 1 year now in our treatment, you see him standing home doing some steps without any aids. So he is not a walker. We do not do miracles, but he is more safe in standing and can do few steps in his home setting and feels more independent. He is continuing this form of treatment and quite satisfied about this. So let's go to spasticity management. So I'm a fan of FES cycling when I want to decrease spasticity, and additionally also of spinal cord stimulation transcutaneously, and I want to give you some examples. So we have here an example of transcutaneous spinal cord stimulation, and I can show you the immediate effect and how it was previously in his daily living activities, how he used to sit up or how he tried to sit up. That was quite challenging for him. And you all know, if you want to sit up and it takes such a time, it's quite annoying. And if I start the other video at the same time. Here you see him with an immediate effect, sitting up directly after a single treatment of about 20 minutes. And it's quite impressive. This effect does not last very long. It is an effect that lasts after first treatment some minutes. But he decided to continue at home with the device, and he does it on a regular basis 2 times a day before he goes to bed and before he gets off the bed. And we do not use carrier frequencies as a lot of people do, but we decided to do it with other stimulators, not having the carrier frequency and being as effective as the ones with carrier frequency, but less expensive for the healthcare system and also for people who want to buy the devices by their own. Okay, here we have the cycling, and I think if we ask people or we want to show spasticity may be reduced by cycling, we expect that people with spinal cord, living with spinal cord injury, are dedicating time, investing time, a lot of time to get access and to get on the bike before the usage. And this is something you only can experience if you see you have also fun and have other benefits by using fast cycling. And you see a short video now, and I want a little bit to explain, because our team thinks, okay, let's start with some events that people can try it out in a community. And so we are organizing once a year a Fast Venture Day to try out for inpatients and also for our outpatients different system of fast cycling. And so it is an event where everybody can talk to each other, share the experience, and also try the device positively and negatively experiences. Does it hurt? Has it more time? Is the time expenditure too high? But it's quite an interesting and interactive day. And as you have seen it, we enjoy it also together, a little bit socially. We drink something, eat something in the evening together, and share our knowledge and experience from both sides. So only to let you know, and even if the weather in Switzerland is not always so good, some people are very, very consequent and have also fun if a thunderstorm is very close. So that is the story of fast cycling. And so here is a little bit background of it. I don't want to dedicate more in detail on it, but this person decided, you have seen him in the video, to use the FES cycling system for reducing spasticity and treating his cardiovascular health. And in the evening, another stimulator to apply transcutaneous spinal cord stimulation to sleep better, not to be disturbed by spasms. and this effect now is for about 5 to 6 hours, and this is in his age the normal sleeping time he has, so he has a quiet and not disturbed sleep now by using this. Good. So we have positive side effects by cycling. We have reduction of spasticity. We have the impact on skin and bone health. We have increased cardiovascular fitness, and we have a positive impact also on the well-being because he's cycling with the family. Good. Now to my last point, I want a little bit to look to the bowel management, because bowel management is really an issue in the population with spinal cord injury affected people. So we performed an own study where we did electrical stimulation on the abdominal wall 13 minutes before regular defecation, not every day, before regular defecation. And the parameters are seen here. And we did it over a certain period of time. It was at least about 24 weeks with a following up period. And we could show that the defecation time was reduced, and also the transit time was of the food, of the intaken food, was reduced drastically and statistically significant during this period. And we had one participant having a transit time of about 160 hours measured by cone test, and we have normally in between 24 to 32 hours. He could reduce it to 50 hours, and that made for this person really a difference of well-being, not feeling bloated and not feeling disturbed by having this belly. So that was quite amazing, and interestingly, all our participants decided to continue after study completion with this stimulation at home. The trial was taken out at home. We did it with telemedicine. We did all our assessments, and the benefits had directly an impact on their quality of life. So our pathway to guarantee sustainability of the treatment effects is that we want that electrical stimulation, however you do it, is continued. Either it is self-administered at home. We try to provide the technical assistance, the technical equipment and the assistance. Of course, if you use technology, you have a little bit to have a technical ambition to use it. But we provide regular follow-ups and availability by phone and WhatsApp and however, and we do it 8 days a week. So if somebody decides, okay, I don't want to do it at home, then we provide the possibility to use in a regular base treatment in an ambulance setting with long-term treatment. But we have to fight sometimes with insurance of the acceptance that it will happen, that we can make it happen, that we can treat long-term. But if once we could convince the insurances, and that's a hard work, then we have only to write once a year to argue that the treatment should be continued. So, therefore, I want to end with the words, implementation begins where doubt ends. So what feels impossible at first often becomes routine with knowledge, practice, and support. And all those work would not be possible if I would not have such a beautiful team in the background helping me and having the same mission and ideas in their mind. Thanks a lot. And I'm open for question.
Thank you, Dr. Birch-Parada. That was a wonderful talk and so nice to see all the wonderful work that you're doing. We are at time, but we can take one question if there's anyone who has a question. You can also leave questions or comments in the chat, and I'm sure Dr. Birch-Parada can respond to those as well. So maybe I'll ask one quick question. For what advice would you have for us in Canada if we want to look at trying to start up a center of our own, like what you have?
So I would advise to start with one topic, not with everything at the same time. So, and to decide to dedicate with one, and I would, if I could recommend something, I would go for FES cycling, because that is something a lot of people can benefit with in different areas from, and then to set this up. And if you see this is a successful story, then try to include other methods stepwise. And for sure, you can get it run. And I started with my first treatment in '92 with electrical stimulation. So it took quite a bit until this was going on. But stepwise is really, I think, something that should be done. And then you will for sure be successful.
Well, that's wonderful because I think we've already started a FES program, at least in the western part of Canada. So we're at step one and hopefully we can build from there.
Yeah, for sure you can. I know that you are doing great work there.
Thanks very much. If anyone has any other questions or comments, please feel to add it into the chat and Dr. Bursch-Prada would be happy to respond back. I'd like to introduce our next speaker now. Please welcome Dr. Jose Zarifa. He's a Kite Chair in Spinal Cord Injury Research, a Senior Scientist and the Associate Director, Scientific at the Kite Research Institute, Toronto Rehab University Health Network. He is also an Associate Professor at the Institute of Biomedical Engineering at University of Toronto. His research interests focus on neuroprosthetics and technology for upper limb neurorehabilitation, encompassing work in wearable sensors, neural interfaces, electrophysiology, and machine learning. Dr. Zarifa's team was awarded the grand prize in the Spinal Cord Rehab Innovation Challenge, a national competition focused on new tools to measure rehab activities and their impact. Welcome, Dr. Zarifa.
Great. Hi, everyone. Share my screen here. Can everybody see the screen?
Yep, we can see your screen.
Great. Thank you. Well, thanks everybody for being here. Thank you for the invitation to speak. So what I wanted to do today was just give a quick little update, I guess, or primer on some recent developments and technologies that we can use to track rehab activities, with a focus on, again, what's maybe a bit newer and also what how feasible it is to use them today, right? Like, so what's applicable today versus what's a longer term perspective. Sorry, very briefly, sorry, there's ringing here. Very loud. All right, so just very briefly, like just for some context, like why are we interested in this? Like, what's the point of capturing, quantitative data in the context of rehab activities? Very briefly, either it's in the context of giving care to a specific person, and we want to be able to have information about their status, be able to have data that can inform, the decision making in terms of how to proceed with different types of therapies. Or at a more macro level, we can talk about the system level where we want evidence about new interventions. We want to be able to track before and after, quantify the effects of therapies, generate evidence that kind of lead to best practices. In both cases, of course, the long-term goal is to improve client outcomes. And so we can capture quantitative data using clinical assessments, manually, visually. So why would we need to use sensors or want to use sensors? So there's different reasons, right? But some of the common ones would include the precise measurements, getting more fine-grained information, which you maybe would be able to do manually or visually with kind of manual tools. So that can help to track finer changes or detect subtle improvements. It could be for workflow reasons. You might be, depending on how it's implemented, you might have technology that helps to automate the gathering of data, the gathering of information, and therefore you can get more information about the process without increasing work requirements. And my personal favorite reason is the last one, which is to get complementary information, different information. It's not about getting the same information that you would get otherwise, but a little bit more precisely and maybe a little bit faster. It's about getting information that you just wouldn't have otherwise. And so we can talk about complementary technologies that give you neurological information or information about what's happening at home, for example. So with that context, I'm going to touch base on three particular types of technologies today: markerless motion capture, surface EMG. It's not new, but I'll tell you why I'm putting it in this context, and egocentric video. There's other things we could talk about, like things like activity trackers, for example, or data you get out of an rehab robot or an FES bike that's kind of tracking session data. But there's nothing really particularly new in those areas, and I think you probably have all a good sense of what you can and can't get out of them, so I won't spend too much time on them. But so I'll focus on these three things. So what is markerless motion capture? It's basically software that takes regular video and finds people's joints in it, right? So previous motion capture systems, you needed to wear special markers and you needed special cameras, but more recent technologies, they use AI to process videos. And so you can track movement without any special setup, right? So it's very appealing in the sense that you can just put a camera there and that's all you need to do. So it's very easy to integrate this into flexible settings. What do you get out of it? The kinematic information, things like range of motion, smoothness, motion trajectories. And so it's very interpretable, right? So to what extent is this usable, right? So like today. So there's obviously ongoing research, but some methods are becoming quite accessible. So one example would be MediaPipe, which is a software package that's put out by Google. It's gotten, there's a lot of uptake. So is this something you can use today? Probably. It still requires a little bit of setup, like software setup, but it's kind of like at the point of like if you've got like a high school student who's volunteering and who's like good at coding, they could do it, right? You don't need like a team of PhDs to do this. So a question though becomes, is this accurate, right? How accurate is this? So we know it's not quite as accurate as marker-based motion capture, but they're getting better. And the big question here is it equally accurate if you've got people who have physical impairments versus these AI systems that have only seen people who were uninjured previously. So this is some data from a study that we did. The different graphs here correspond to different pose estimation methods, so I won't get into it, but for each one of them, the orange bar is people with stroke and the fuchsia bar is uninjured people. And so we wanted to see if with movements differences after neurological injuries, the systems would be equally accurate, and they were. So there was no difference in the accuracy of the systems between the two populations. And this is consistent with other data in the literature. So I'm pretty comfortable saying that the accuracy is similar for people with and without disabilities. That supports that they could be used in this context. The second technology I wanted to talk about was surface electromyography, which is measuring bioelectric activity of muscle using non-invasive electrodes based on skin. So this gives you neurological information, right? So like it's, for example, you can see if there's innervation in a muscle, which can be very interesting because we know that sometimes after spinal cord injury, some muscles won't have any visible strength, but you can still detect the electrical activity. So it really gives you additional information about the remaining information. You can see things, for example, like spastic contraction. So it gives you a different angle on a number of different relevant issues. When you hear EMG in a clinical context, often it's intramuscular EMG done by a neurologist, whereas surface EMG tends to be more used in research. In terms of tools for therapists, right, clinically facing tools for rehab, some tools include EMG, like for example, some stim units will have EMG biofeedback options, but there's not a lot of tools that are intended for diagnostic purposes for direct for like frontline therapy situations. However, the technology is actually not that complicated, really, the instrumentation. So there's lots of options to make stuff, to create custom systems, right? And it's at the point where even you can buy like EMG sensors for like your Arduino. Like it's not very expensive, very complicated to create these systems. So they could be customized. So the question is, well, is it useful, right? So this is an example from a study that a group of MSc PT students at U of T did with Kristen Musselman and myself, where we asked a few therapists about their views of how relevant EMG was to them. And you don't have to read everything here, but just a couple of main points was in terms of perceived usefulness. So it wasn't their like top priority. Like they obviously were more interested in kind of really functional outcomes, but there was recognition that it was a valuable complementary modality in some cases, again, to see if there's some remaining information was an example that came up. But then the question was, well, is this usable? You know, like what would it take for this to be integrated into the workflow? And a lot of the barriers that came up were really about education and having clear protocols so that you would be able to say, okay, well, if I see this, then I should do that, right? So that having that more concrete link to the clinical workflows was identified as a need. This is an example from a study that we did to kind of give a glimpse of an answer to that question. So here we were looking at people receiving FES therapy for upper limb function, and we wanted to use EMG to predict which muscles would benefit from the therapy. So we measured EMG on the muscles that were about to start therapy before they started. Then we tracked the strength recovery of the different muscles, and we used EMG to try to predict which muscles would benefit, right? So the idea, long-term goal being that a therapist could use that information to decide how to spend the time with a given patient. So that's kind of an example of a use case for EMG. And as I mentioned, it's possible to create new EMG devices that are suited to specific clinical use cases. This is work done by Professor Julian Liu at U of T in collaboration with our team, where they created these EMG patches and validated them against commercial systems. So there's this possibility of creating different form factors to put things in the hands of therapists that might make them more relevant in an APT context. And then the last technology I want to quickly talk about is egocentric video, which is something that our lab has had a lot of interest in. So this is video from a wearable camera, like a GoPro basically, or smart glasses maybe is starting. And so it's recording what the person sees. And what we do is we use our machine learning to automatically process that video and extract information out of it. So what we like about this is it gives you information at home, but it gives you a lot of context, right? So it's not just recording the person's movements, it's recording the context in which they're happening. And so I'll tell you more about it, but in terms of what can we do today, well, you can collect this data right now. Like the AI-based analysis is still something that is being developed, or that's at different stages, but you can send somebody home with a GoPro and you can get information. And as we'll see, there's a lot of information in that. I'm going to pause it in the survey. So here's an example of what that data looks like. So here's a person with an SCI preparing food at home, and you can see you get information about their hand function, right? But you're also getting a lot of interesting contextual cues. Like here, there's like awkward environmental factors with the angle of the microwave. And so there's gives you kind of a fuller picture of what's happening. So we've use this in a number of ways. So we can use it as tools for researchers, like you're doing a clinical trial, you want to quantify what's happening at home. So we've detected things like how much they're using their hands, what kind of grasp they're using, whether they're using compensation like kinesis grasp. And then we can also use this to give the therapist and to see, is this useful to them, right? So in conversations that we've had so far, and I'll show you some quotes in the next slide, the feedback that comes out is this is really interesting. Like we're not really looking for metrics, but just seeing the videos is cool, and it can inform decisions. And so then the question is, can we take a long video and develop tools to make it easy to find what you need, to summarize them, to make it realistic that in a quick review you can get the information that you need. So conducting long videos, summarizing what kind of graphs people are using, seeing, like, figure out what activities people are doing so that a person can just jump and observe a specific therapy a specific activity that aligns with the goals that they were working on in therapy. So lots of different ways to use this information. And again, back to the how is it relevant to kind of workflow and clinical decision making? We have some quotes from therapists, and so people appreciating seeing the opportunity to see people in their real world context. They identified that gave them different ideas about what they were finding difficult or not. In some cases, some safety concerns came up. That they said, well, if I had known that, I would have worked on this with them, right, to address that. And so one person said, you opened my horizon as a therapist. So again, this idea of trying to link the technology from the sensors to clinical decisions. So I'll leave it with that, right? So there's a greater variety of tools that are becoming available and getting to the point where realistically somebody could just use them today. But we really need this conversation about, like, how does this new type of information fit into decisions that the clinicians would be doing, and that really requires ongoing discussions, and that's something I'm always happy to discuss with anyone. My contacts at the bottom there, yeah, I'll stop on that note. Thank you.
Thanks very much, Dr. Zarifa. It's nice to learn a bit more about tracking. We have time for like maybe one question. If anyone has a question or comment, you can either raise your hand or type it in the chat. So maybe I'll ask a quick question. Thinking about activity-based therapy and within a real world context, so thinking about inpatient, outpatient, or even a community setting, what would you say is our low-hanging fruit of what we can target next in terms of tracking within those settings?
Yeah, I think EMG has potential, and it's not new, but it's so I think everybody kind of knows what it is, but it's not used in that way as much as I think it could be, right? And again, there's a bit of like obstacles in terms of just getting equipment kind of that's convenient, but I think the information is such that because it's neurological information, right, in an SCI context, I think it gives a lot of additional insight that would be intuitive, right, to people in this space, and they kind of would have a sense of what to do with. Like, for example, okay, well, there's even forgetting like the machine learning based predictions and so on, you can look at things like, well, is there innervation? Is there maybe a lower motor neuron injury? It doesn't directly tell you that, but there's a reflection that is reflected in the signals. So you can get that information about, like, okay, where which muscles would be good candidates with what kind of approaches. So I think that the link to decision making is potentially fairly close. So that's good. And then again, egocentric video, we've gotten feedback that just looking at the videos is immediately insightful. So I think I encourage people to to play around with that. Again, like, we're doing a lot of work on like kind of summarizing and making it more convenient, but fundamentally you can just capture video, GoPro or just people's cell phones, and just we've had a lot of good feedback about how insightful that was and how actionable that was for therapists. Like, if I had known they were doing this, I would have done that, right? And it was very clear. So I think there's a lot of techniques there that like give you very interpretable, very usable information.
Yeah, no, I agree. It's great. So thanks very much. If anyone has any other questions, feel free to type it in the chat, and I'm sure Dr. Zarifa would be happy to reply back. I'll pass it on to Hope to introduce our next speaker.
Hi, everyone. I have the pleasure to introduce Dorothy Barthélemy, PT, MSc, PhD, who is a professor in the physiotherapy program at the School of Rehabilitation, Université de Montréal. She was trained as a physical therapist and has a background in neuroscience with specific expertise in spinal cord anatomy, neurophysiology, and sensory motor control. She completed her PhD in basic neurophysiology under the supervision of Serge Rossinol at the Université de Montréal, followed by 2 postdoctoral fellowships. She subsequently established her laboratory at the Université de Montréal, where her research investigates spinal and supraspinal mechanisms underlying balance, control, gait, and arm movement. In this presentation, she will present the CIME program, which she leads at the IURD-PM. This program aims to develop and implement approaches to assess and optimize neuroplasticity following SCI in the subacute care setting, with a particular emphasis on innovative interventions that combine ABT and neuromodulation to enhance functional recovery trajectories. I'll pass it over to you.
Thank you, Hope, for this introduction, and thank you very much for this invitation to discuss at the ABT Expo. So I'm just going to share my screen now. So I think you might be able to see my screen now. So I will start. Again, thank you for inviting me for this presentation, to give this presentation. My name is Dorothy, as Hope just mentioned, and this is the work of many people. So I'm here presenting, but really I'm just reflecting the work of many people that I will introduce later. So this is the plan of the talk. So I'll try to just be within 14 minutes, as I'm quite enthusiastic about the SIM program, which CIME, and I'll explain what the acronym means. And then at the end, if I have time, I will just go into one of the projects that we are developing within the SIM program, which is hoping to improve lower leg function. So yeah, the IUR-DPM, or the Rehab Institute of Montreal, basically is at the heart of the care continuum of people with spinal cord injury in Quebec. So in Quebec, the way the government is separated into the eastern part of Quebec and the western part of Quebec, and we are at the only rehab center for spinal cord injury in subacute care in the western part. So the clinical team at the IRGLM is already at the forefront of the best practices. So they are already integrating activity-based therapy within the techniques. And actually, a lot of them are part of the ABT COP of practice, the committee of practice. However, even though we are getting there and we're integrating into the clinical environment, there's still suboptimal treatment intensity. So due to different elements such as lack of resources, short durations of stay, so we are unable to make it systematically that people will get in subacute care, the rehab and the activity-based therapy rehab they could to eventually go to full functional recovery. Just to say that we also have acquired different equipment recently, the FES bag, the GEO, and the GEO will be at the base at the center of what I'm going to talk about today. So I think I don't need to introduce what activity-based therapy is to this group. It is intensive, repetitive, and it uses plasticity actually by repeating this movement and being so intensive above and below the lesion. However, what I will say is that recovery is still partial, and one of the reasons might be that it's also indirect activation of the nervous system. An emerging practice, neuromodulation, but more specifically, transcutaneous spinal cord injury, has been shown to be able to increase the excitability of the neuronal networks. How does it do it? It kind of activates dorsal root afferents and probably increases the excitability of the neurons that will receive the command from the spared corticospinal pathways. So where it's really different, because FES will try and induce this movement, whereas here the stimulation will not try to induce the movement with the stimulation, will try to facilitate the movement using spared corticospinal pathways. So then the research question is, within our context, that within clinical context at the RGLM, ABT is already used as much as possible within functional rehabilitation. However, the intensity is not systematic and is suboptimal due to lack of resources and length of stay. And so we, discussing with the clinician, thought about the possibility of co-construction of an approach that could address these limitations. And then the research question becomes, could rehabilitation time be optimized by combining best clinical practices with emerging neuromodulation approaches? And our answer was the SIM modulation program. So we were funded for 5 years to try and use this living lab approach to try and to build this program. I will talk to you about the objectives later, but as you can see in the figures around the table, we have several meetings with clinicians, researchers, managers, students, patient partners. So it is really a co-construction, and where we look at not only the impact on the health and on the movement and on the function, but also psychosocial impact as well as in the community. So then the objectives are, if we want to say it out loud, to co-develop and implement this SIM program, this intensification and neuromodulation clinic for individuals with spinal cord injury. We will try to design, test, and implement innovative interventions that will become sustainable, we hope, within the spinal cord injury program. And we will evaluate this implementation again, but I will not touch on this part today. So again, as I said in the beginning, I'm here speaking to you, but I'm representing many other people. So as a principal investigator, my expertise is in neuromodulation, electrophysiology, and recovery after spinal cord injury. The co-principal investigator, Diana Zidarov, is an expert in implementation science and knowledge transfer, as well as several researchers that have different expertise in the different projects that we are leading. Clinicians are part of the research team, actually. So it is not just that we're bringing some new techniques, we are constructing it with them. Physiatrists, physical therapists, all the clinicians that are actually involved in the rehab at our center. We also have people with lived experience partners, caregiver partners. They form a committee, and they also talk and have a say in this co-construction, as well as, of course, research, clinical professionals, and all the students. So, but there will be too much to say, but these are really a lot of people getting there, and this is what is needed to try and get this SIM program on its feet. There are several projects here. Sorry, it's all in French, but these projects I will not talk about, but just to give you an idea that the projects that are being developed. This first project on the upper limb will be discussed a bit later by Sujata Sinha, who is a postdoctoral fellow, and I will concentrate on the lower limb. So I will take the remaining of the time to talk to you more deeply about the spinal cord stimulation that we combine with the gait training to improve lower limb movement. So this is a spinal cord injury where we put over the lumbosacral enlargement. We are using a gait robot for people that are not able to move. So it's an end effector, the GEO. And for people that are more like CED, advanced, that are able to start doing movement and walking, we use body weight support training. So basically, as you know, after spinal cord injury, people lose lower limb function and walking ability. This ambulation is crucial for independence, participation, and quality of life. Yet, despite advances in care, meaningful recovery is still limited, and highlight the persistent therapeutic challenge. So basically, as I mentioned, the SIM program tries to complement or pair spinal cord stimulation as well as activity-based therapy. And our hypothesis is that by combining this, will be feasible in subacute clinical practice. And it will hopefully lead to better recovery than ABT alone. So these are our hypotheses. To do that, we have 3 aims that I will talk briefly today. First, the feasibility. Can we do this in a subacute hospital setting? Then I'll talk to you slightly about some of the preliminary data we have on the effects of the intervention, both of sensory motor recovery and on neuroplastic changes that could occur at the spinal level. So the methods, the participants in both groups are still undergoing usual care. So the recruitment will be of patients over 16 years, Asia A&D. So it's really a pragmatic trial, so that we try to recruit everybody and see maybe the therapy will be better for one or the other. Some patients or other patients. But then once we recruit, we have a baseline assessment. Then we separate them in sham and intervention group. Those groups receive 20 sessions of 40 minutes training, and then of either ABT and sham or ABT and TSES. And we do 2 other assessments, post-training, and 1-month follow-up. So the training, like I mentioned, is a robotic-assisted gait training or treadmill overground combination. Of course, the therapists are there to make sure that we always go to the maximum of recovery of therapy, and that the people are really training intensively. Of course, we separate the way we decide to separate either if somebody is going to go to robotic gait training or treadmill is based on the SWOT, which is the standing and walking assessment tool. The simulation will be transcutaneous. So we'll go over what you saw earlier was one active electrode over the lumbosacral enlargement and then other electrodes on the iliac crest. But we also have now much more electrodes. So we can use 6 discrete electrodes to try to be more specific to certain muscles. I can discuss that at the end if you have questions on this. We always do a mapping first, determine which is the best frequency for people, and then we try to use an intensity for the experimental group, the intensity that is at a facilitation level. And for the sham group, it's just more sensory thresholds, just enough that they feel there's something. So we train them 4 times a week for 20 sessions, 40 minutes of active treatment. So here is the demographic and clinical characteristics of our participants. So far we have 7. So this feasibility study is really not powered to look at effectiveness. So it will lead to a randomized clinical trial. But for the moment, we are trying to do this feasibility study. And when we see the AIS at admission, AIS at discharge, the number of days after the lesion. So we can see that several of them increase their IIS, but it's not to say that it's because of the simulation. It might have been there anyway, but this is something we're going to look at in the efficacy trial. So the recruitment was done. We screened 14 patients. 7 of them were enrolled, and currently 7 have completed, and 1 will start soon. The retention to post-training was 85%. 1 person had to drop due to early discharge. So as I said, we're looking at the western part of Quebec, which means that people are living very, very far. And once they're discharged, oftentimes they're unable to come back. And this is why we keep the number of sessions to 20, that we make sure that most of them will be able to participate in all 20 sessions while they stay. Adherence. So 82% of the people 82% of the training sessions were completed. So out of 20 sessions, 16.4 sessions were done in admin, and a high satisfaction with the program was reported. I will not go into that, but there was exit interviews for all of the participants, and that will be qualitatively assessed and analyzed, but I will not touch it today. However, there were some adverse events, nothing serious, but hypotensive episodes, skin irritation, harness-related pain, and fatigue. I mean, of course, this is something that's happening in subacute, and our solution was to have frequent communication with the medical team. We have a secured communication channel with them and a security committee. Importantly, all patients were able to pursue their training once the event was resolved. So a hypotensive episode, for example, can be since they are being standing up and starting to walk, especially patients AIS A and B. What they will do, they might have a decrease in the pressure. So then, of course, we have to address that. But then once they reach, for example, the 10th session, usually they don't have any more of these. So this is also something we'll look in the efficacy trial to see if we're able to induce tolerance or increase tolerance with this training. So I'm finishing with those small preliminary data. So looking at the lower extremity motor score, we have the experimental group and the sham group. You see that both groups from pre to post were able to improve actually their LEMS. And as you can see here, this is the mean LEMS. I'm sorry for the French here. I couldn't change it before today. So they both increased. There seems to be an improvement, a bigger improvement in the experimental group, but really we cannot say anything. I mean, we're not powered for efficacy. For the sensory score, what we see is that in the experimental group, there was also an improvement from pre to post. There was not much improvement to pre to post in the sham group. And this is the difference that you see between the group, the experimental group and the sham group. So during the efficacy trial, we will put a special attention on the sensory function to see if maybe this is something that is even more improved by the spinal cord stimulation. So my last slide is this one. So basically, the clinical outcome suggests that combining gait training and TSCS is feasible in a subacute inpatient rehabilitation center. The preliminary analysis suggests that there's an impact on sensory and motor recovery, and that there's a potential correlation between neuroplastic changes and functional recovery. I have to say that neuroplastic changes, we also look at TMS and SSCPs, the EEGs. We also look at what's going on in the cortex, but there was no time to discuss that today. So there's potential improvement for clinical practice here at ERGLM as well. There's a limit though. So there's a large variability. As you saw, there's not many patients in that feasibility study. And you have to consider the spontaneous recovery versus the training. We are in subacute. So of course, people are going to recover anyway. So one of the way we're going to do to look at that is, within this efficacy trial, not only will we have a larger population, but we will also compare to usual care. So not only will have a difference between the ABT alone and ABT plus TSCS, but we'll also have a comparison with people having not on this ABC, but just the usual care. So that's it, and I just thank you again for inviting me to discuss about the SIM program. As I told you, many people are responsible for this, and I thank all of them as well as our sponsors. So thank you again.
Thanks very much, Dorothy. And I had a few questions about efficacy, but it is time for our break. So I'm wondering if Dorothy would agree to stay on for a few minutes. If anyone has any questions, you could type it in the chat. Otherwise, about a 5-minute break, and Anita will bring you back. Thanks so much, Dorothy.
No problem. Thank you.
Oh, and Catherine says, thank you. She may have a few patients that might be interested in your study eventually. Don't forget to contact us in Montargis once you start recruiting. And Vivian says, that's fabulous. Can you give us a feel for what the stimulation amplitudes were?
Yes. So if I can answer those two questions. So for Montérégie, yes, actually, we are going to be giving a talk on March the 18th to the entire consortium of the western part of Quebec. And I think Montérégie is part of it. So absolutely, there will be discussions there, and they'll have time to explain much more the other projects as well. So that would be really, really great. And yes, for the amplitudes, you are absolutely right. So for the amplitudes, there are two things. First of all, at the first, so it's a feasibility study. So the first couple of patients, we had to adjust because we thought that we could go until tolerance, but actually tolerance, we have to push tolerance because if the stimulation is not high enough, really, we don't see any effect. And just to give you an idea, I can give you just a few ideas of what we have with the stimulation intensity. The mean intensity that we had during training was 38 milliamps. This is the mean intensity. So many of them were above, some of them were just a bit below. But these are the intensity we used for the experimental group, whereas the sham group, it's around 2 milliamps. And now the other thing, I think this question that you mentioned was about, are we sure we're recruiting only motor versus sensory? So we are doing a parallel studies with healthy participants where we look at, for example, the post-activation depression. So we want to see, so many people do paired pulse, but we do many pulses in a way that we can see that is it much more sensory fibers that we are recruiting, or are we also recruiting motor fibers? For the moment, I cannot tell you we did that with the patients just due to time and convenience. It didn't occur, but I think this is something absolutely we should also do in the next patients, also to make sure and to be able to determine and identify what type of afferents we are recruiting. So yeah, that's an excellent question. That's true.
And I have another quick question. Well, first, Bill Bearable says, very interesting study, Dorothy. Then Christy, we have 2 minutes, so you can also type this in the chat if you run out of time. But she asked, what are the parameters used for the TSCS?
Yes. So when we start, before the first screening, we do this kind of mapping. So the parameters are, the first few patients, we use the DS8R, so which means that we use 1 millisecond pulse width. And then we always try to see where exactly the best responses are location-wise as well as intensity-wise. And frequency-wise. So frequency, we go between 30 and 80 hertz. One of the reasons that we are switching, and I just mentioned it, switching to not only one electrode, but 6 discrete electrodes, is because sometimes we do need to be able to improve and to be more specific to the muscle. So what we did at first, everybody starts with this big electrodes because we don't know what they're going to be having. We just know they're starting here. We don't know if they have movement. Some of them don't have movement at all. So we're starting to increase everything. But as soon as we see that some muscles are much more responding, then we're going to stimulate much more discrete electrodes that we can have more impact on the muscles that are actually starting to progress. But all of them, we always do this mapping again between 30 and 80 hertz. The pulse width now is more 400 microseconds because we're using the MyoTrack when we do the training with the clinic in the clinic. And yeah, that's I think that's, and the intensity is probably not at threshold. Of course, it's going to be below threshold, but a facilitating intensity.
Okay, thanks very much, Dorothy. And then we just have about 30-ish seconds or less. If you want to do a quick wiggle or stretch for those of you who stayed for the questions. And then I'm going to pass it off to Anita in, I think our watch stopped for a second there. So I'll pass it over to her when she interrupts us to bring us back.
Hi, everyone. So welcome back from your short bio break, but we'd like to try and keep things on track for all of you. So I'd like to introduce our second keynote speaker for this session. Dr. Matita Milosevic is the Director of Neuromotor Rehabilitation at the Miami Project to Cure Paralysis, an Assistant Professor of Neurological Surgery and Biomedical Engineering at the University of Miami. He leads a translational research program focused on developing brain-computer interface and neuromodulation approaches, elucidating neuroplasticity mechanisms underlying recovery after spinal cord injury, and advancing clinical translation of neuromodulation-based therapies for neuromotor recovery. His work integrates neural interfaces, neurophysiology, and rehabilitation engineering to restore volitional motor function. Dr. Milosevic received his PhD in biomedical engineering from the University of Toronto and previously held academic and research positions at Osaka University and the University of Tokyo. Welcome, Dr. Milosevic.
Well, thank you very much for the intro, Anita, and it's great seeing everyone again. And thank you for the opportunity to present to the group here and give us an update on some of the work that we've been working on over the past years, and specifically in Miami. I just want to make sure that my screen is sharing correctly.
Yes, we could see it.
Excellent. So again, thanks so much for the invitation to present here today. Today, I'll be talking about how our brain-computer interface neuromodulation approaches are used specifically to help potentiate activity-based therapies following spinal cord injury. So before sort of getting into the details, I kind of always like to include this motivation slide, which gives me kind of an overview of some of the motivations that we use behind our neuromodulation approaches. So if we sort of imagine how one is able to, perform this simple yet, I guess, complex set of commands to execute, a grasping maneuver. There are multiple sort of centers within the subcortical and supraspinal circuits that are involved in this process. So specifically, just to briefly summarize, we use the visual information to locate the cup, motor areas to plan the movement. Spinal cord carries the information back down to the motor neurons, which then can perform the grasp. And then the loop doesn't end there. That's the important point. The sensory information is conveyed back to the central nervous system via the spinal cord, which does some of the regulation, and then some of the basal ganglia circuits, which can, correct and compensate for some of the control. And then finally, the information is relayed back to the sensory cortex that the message has been received. The point is, and the motivation behind some of the work is that this is a closed loop sort of feedback system which can be optimized and fine-tuned through practice and learning. And we try to leverage this sort of central nervous system neuroplastic ability to develop our approaches for neuromodulation. Now, as you all know, spinal cord injury obviously disrupts both these descending commands, which present as motor sort of paralysis, as well as the ascending feedback information to the central nervous system, which presents as sensory deficits, which also provides a challenge to potentiate some of these circuits using exogenous stimulation and other neuromodulation approaches. We have covered a lot of the work up until now, looking at sort of functional or peripheral stimulation techniques that co-activate both efferent and afferent circuits to help individuals perform certain movements. Recently, as you've also been seeing, there is sort of an emerging interest in looking at more central stimulation techniques, such as spinal cord stimulation, or I guess it's become more prevalent. Nonetheless, these typically tend to focus on these enabling effects and trying to amplify the descending circuits. The focus of our work is specifically in trying to understand how we can use electrical stimulation to excite the central nervous system most efficiently, and this feedback information that we're providing to the central nervous system. And to that end, we use relatively simple closed loop brain-computer interfaces to sort of close this loop of movement intentions and stimulation, which we hypothesize, and as I will be showing you, can be more efficient in driving neuroplasticity. And then specifically, the pitch that I would like to present in this talk is how this closed loop brain-computer interface neuromodulation approach is really, I guess, nicely set up to help us potentiate activity-based therapies. Most of the talks that I will, or most of the scientific focus that I will, present today will be focused on the corticospinal tract, because it has been shown as one of the major tracts for, responsible for recovery of voluntary function following spinal cord injury. But there are many other tracts, as was previously presented, that also contribute to the recovery of function. But I will mostly be focusing on the corticospinal circuits modulation. So, again, the overarching hypothesis of the talk is that, this, tonic stimulation, it has this effect that it can, essentially lower the activation threshold of the spinal circuits and potentiate these descending sort of commands, and the training enhanced by this spinal tonic continuous spinal cord stimulation can lead to these long-term changes in the motor function by modifying these synaptic connections at the spinal and corticospinal level. The hypothesis that we have is that, and specifically related to this closed loop BCI neuromodulation, is that we can elicit Hebbian-like synaptic plasticity more efficiently using this closed loop brain control interface triggered stimulation, and the training, long-term training with this approach can potentiate corticospinal circuits to improve motor function following spinal cord injury. Okay, so I'll present a series of studies that have kind of led us to some of the more translational trials, just to kind of give you some of the background preliminary evidence for this work. And then I will present some of the early interim analyses of some of the pilot clinical trials that we're running to improve function. So initially, we wanted to really understand and become convinced that this closed loop BCI-driven stimulation is indeed more efficient in targeting and facilitating the corticospinal circuits. So we wanted to first understand how, movements and how we can, use descending drive to essentially excite the central nervous system. So first, we just sort of developed this system to really understand how motor imagery can potentiate the corticospinal circuit. So we had able-bodied individuals sort of perform flexion and extension. We measured corticospinal motor evoked potentials. And as expected, when somebody flexes their wrist, we see facilitation with the background activity of the flexor capri radialis. Similarly, if somebody extends their wrist, we see facilitation of the extensor muscles with the increased background activity compared to rest. Now, importantly, we could also use this motor imagery to elicit similar effects. So if the hand stays at rest, or if somebody's unable to perform the movement, they imagine extending or flexing the wrist, we can get, targeted facilitation of the corticospinal tract. We then wanted to see whether or not, or how we can develop a simple, non-invasive way to detect these movement intentions using EEG. So we would again show them sort of a series of motor imagery tasks and ask these individuals to imagine certain movements when recording a non-invasively electrical activity from the contralateral motor cortex, and in this example from the C3, which is the motor cortical representation of the contralateral arm. And in order to distinguish between the rest states, when the person is just looking at the screen, and the sort of active states when they're actively imagining the movements, we would sort of calibrate the system to detect this event-related desynchronization activity in a certain frequency band that might differ. So this is another individual that has a slightly different profile, but nonetheless, they still have this very clear difference between the rest and active states that we can leverage to detect these movement intentions, which we know sort of can provide descending sort of drive modulation. Once we do that, so we have a calibration session, they come in, we sort of figure out which electrodes are active and in which frequency band, and then they would come in to the next day to do, in this proof of concept study, we use electrical stimulation of muscles to sort of just extend the arm, right? Or extend the wrist. So this is what it looks like. So we would have the person imagine the movement. Once the system detects it, FES would be applied to the extensor capri radialis muscle to extend the wrist for 5 seconds. There is a ramp-up period, but again, so the movement is detected, and here on the side you can see the stimulation artifact, and eventually the hand going up for a couple seconds. So this is an intervention, 25 minutes. These are proof of concept studies, no activity-based therapies yet, but we'll get there. 25-minute intervention. We did this in 12 individuals, and we sort of compared this BCI-controlled FES approach to just applying FES with the screen off, sort of in random intervals. So something like, potentially like something like that's done in the clinic if the patient is really not paying attention to what movement they're performing. These were matched, not to go into details for the sake of time, but we ensured that the stimulation delivery was consistent and matched between the two different sessions in this crossover design. And then we looked at pre-post corticospinal excitability. When we looked at this, just FES without any BCI, there were no changes in corticospinal excitability after a single session, don't forget. That doesn't mean that it's not effective. It just means it's a single session. However, when we did this BCI-controlled neuromodulation approach, we could get this relatively robust potentiation of the corticospinal circuits for at least 30 minutes after the intervention in the muscle that we were targeting using electrical stimulation, but not in the FCR. Okay, so we're happy about that. We then wanted to see whether engaging the motor cortex or some of the other areas which we could sort of use for BCI sort of related control purposes was more effective in driving this neuroplasticity. So we did like another study, again in 12 individuals, again 25-minute sessions, but instead we compared this, prefrontal versus motor cortical BCI system in controlled FES. Success rates were similar between the two sort of interventions. However, the motor cortex BCI system was slightly faster in detecting these movements. Long story short, we did a lot of different analyses, but M1, so motor cortex-based BCI FES was again very or more efficient in driving these short-term neuroplastic changes in the corticospinal circuits, which in this time outlasted the intervention by 60 minutes. And this was a 25-minute intervention, but we were able to get potentiation for at least 60 minutes after the intervention, even though there is some washout, as you can see here. While the prefrontal sort of BCI FES approach did not elicit the same effects. Okay, so we're happy about that. In parallel, and I'm not going to go into the details because of time, we had another student who was really interested in these descending drive neuromodulation, and she essentially used repetitive transcranial magnetic stimulation to really systematically study how pairing descending sort of drive with functional electrical stimulation of the muscles can be sort of optimized and fine-tuned. The long story short is that cortical facilitation, as listed by this intermittent theta burst stimulation protocol, before the stimulation of muscles can facilitate corticospinal excitability, sort of agreeing with our proof of concept studies with BCI FES. Effects are not only reliant on spike timing dependent plasticity, so timing is important, but there are other mechanisms which play a role. Frequency encoding, so if you match the frequencies, you can further drive these short-term neuroplastic changes. But most importantly, cortical activation or this descending drive activation is essential, at least for driving these short-term pre-post single session changes. So just applying a single session of FES never resulted in any significant changes in the corticospinal circuits. Whereas if you paired it with some sort of descending drive, you always were able to elicit, or descending facilitation, you were always able to elicit pretty robust facilitation. Okay. As you've also seen in some of the other talks, we then became interested in could we, elicit sort of similar effects through spinal stimulation. So we conducted a proof of concept study where we, instead of stimulating the periphery or the mixed sort of nerve bundle that sort of co-activates both the motor and the sensory fibers, we wanted to see if we can selectively activate these dorsal root sensory fibers, which essentially then can modify these synaptic kind of connections within the spinal cord. So we wanted to see whether that is also an efficient sort of approach for driving these short-term neuroplastic circuits. So there is different configurations, settings that we can go into a lot of details talking about, but essentially we first needed to figure out how to place the electrodes and how to configure the montage so that we can get this selective sensory or afferent fiber activations. And to do that, again, to make the long story short, we leverage this paired activation or paired stimulation post-activation depression protocol, which essentially if you send two pulses with a very short interstimulus interval, roughly 50 milliseconds, and if you are able to elicit this depression of the second evoked response, you can sort of infer that you are selectively activating the dorsal roots or preferentially activating the dorsal roots and transsynaptically essentially getting the activation of the motor fibers. Whereas if you were only sort of activating the motor fibers, you would not get this post-activation depression. And we used various sort of experimental conditioning paradigms to sort of confirm that. We weren't convinced, and then we also developed this computational sort of finite element model where we simulated different fibers that are present in the ventral and the dorsal roots, and we sort of estimated based on this, again, computational analyses, the activation thresholds. And the conclusion is that as long as you don't crank up the stimulation intensity, you can be selective in activating these A alpha and A beta proprioceptive and cutaneous fibers before you get to the motor fibers. Now, having said that, if the stimulation is too low, then you might not activate anything. If the stimulation is too high, you co-contract everything, okay? So there is still I guess the point is that it's still extremely important to spend the time to set the stimulation intensities and the location of the electrodes to actually get the activations, as was previously mentioned. Okay, so now we were kind of ready. So we, again, 25-minute session, 12 individuals, again, different study, different individuals. We tested or compared this BCI controlled to just spinal stimulation without this descending drive sort of approach. So again, we had like a BCI controlled spinal stimulation, and then in a crossover randomized sort of single session, effect study, we looked at like this random TSCS, right? So same individuals came to different sessions on different days in a randomized order. Same sort of BCI approach. We predominantly target the motor cortical sort of areas where we get this like very nice, robust event-related desynchronization. Once we do that, we trigger stimulation to activate selectively the spinal circuits for 5 seconds. And once again, just re-emphasizing, setting the stimulation intensity is important. Too much is not good. Not enough is also not good, because then you don't get any actual activation. And to do that, sort of real time, we this time utilized this, again, post-activation depression with continuous stimulation. So essentially, if you get this first response and then subsequent sort of depression, consistent depression, you can sort of infer that you're selectively activating the dorsal roots. Whereas if you get no suppression, perhaps you're activating the motor axons predominantly. And if you get this alteration, you might be sort of right at the edge. So you're kind of getting a bit of both. Okay. We tested pre-post corticospinal excitability, once again, sort of showing that this intention-driven, BCI-driven approach is more efficient in potentiating the corticospinal circuits after a single session. Okay, so you can get this facilitation, which seems to wash out. That might be a dose effect. I don't want to make a conclusion that it cannot outlast the intervention, but for now, we can at least get facilitation with the BCI approach, but we cannot get that same effect with just the stimulation. In fact, we even start getting some inhibition, but we'll talk about it in a bit. Okay, so then, in Miami, we also had an opportunity to sort of start a, first in human sort of clinical trial looking at how we can potentially, translate some of these approaches in a implanted sort of BCI controlled cervical epidural stimulation sort of paradigm in this time, for an individual with a motor complete tetraplegia. So again, briefly to summarize, so this is now, again, shifting focus from transcutaneous to epidural stimulation and from EEG to ECOG in an individual who is chronically implanted initially as part of the first clinical trial with an ECOG sort of Medtronic off-label BCI system done by some of the collaborators and clinicians at the University of Miami. And then subsequently, another sort of follow-up clinical trial, we were able to interface this with a 30-day or under 30-day trial using percutaneous epidural sort of spinal stimulation to deliver this therapy. Okay, so that's kind of the overview of the picture. Now I'll slowly sort of zoom into these different components. So to accomplish this, we were able to essentially use some of the Medtronic devices, but these are not off-the-shelf approaches. So we had to sort of hack our way into it essentially and develop this BCI sort of decoder that needed to talk to this external stimulator in order to interface with these percutaneous leads to deliver the stimulation to the spinal dorsal roots. Again, the BCI system was through these ECOG implanted electrodes, and again we calibrate sort of the electrode, I guess, position to get these like strongest event-related desynchronizations during imagined sort of movements, and we tested different types of movements. And whenever we get this strong event-related desynchronization, which in this case was also in the alpha frequency range, we were able to use that to trigger selective spinal root stimulation for a period of 5 to 20 seconds, depending on which specific task the individual was performing. To make sure that we are, activating the dorsal roots, we again leverage this post-activation paired pulse sort of paradigm. So where we can, get like much stronger post-activation depression, which sort of indicates that we can perhaps more selectively activate the dorsal roots through this implanted approach, whereas where you're doing it transcutaneously, you might be less selective because we don't get such a strong depression of the evoked responses. You have to spend some time, 1 or 2 days, probably in our case, because this was the first individual, sort of figuring out which specific electrode. 2 leads were implanted unilaterally in the cervical region to figure out which contacts are most selective in facilitating some of the muscle activations, and then sort of based on those muscle activation profiles, which of these contacts and configurations would be most enabling and potentiating some of these like reaching and grasping functions. And to do that, like this is the typical frequency range, just an example, but we would start off with 30 hertz and then sort of also increase the frequency at this stage if needed to make sure that we can really get this like enabling effect with different configurations. So it wasn't always 80 hertz, but this example, like we did use 80 hertz stimulation. Okay, so these are the assistive effects. So this is stim on, stim off. Okay, so no stimulation. This is our participant. He's unable to have enough, but you can see with the stimulation. Oh no, this again with the without stimulation. Now stims on. Look at the hand. You see that he's able to generate slightly more force to generate this grasp, and which helps him then, I guess, maneuver the object, move it around, work with our physical therapist Akiko to engage in various sort of activity-based therapy type tasks. So once again, he's able to just repeat a task, generate just slightly more force to help him grasp this object. Now, activity-based therapy was integral to this sort of intervention. So we had a 4-week period, so just under 30 days, during which we were able to deliver 19 sessions of activity-based therapy. So every time he would, like we would show him a movement, the therapist would give him an object, and then, he would use this to activate the spinal circuits, and he would perform various sort of tasks. And here are some examples. So some of them were sort of isolated, simple movements where he would either grasp, pronate, pinch, or reach for different objects. And then in other times, these were more combinational tasks where he would be doing different types of tasks. And these were specifically set by the therapist. And throughout the intervention or throughout the 4 weeks, we were able to sort of vary these tasks and essentially make sure that he was able to sort of progress throughout the therapy. Okay, so this is pre-post. We're looking at therapeutic effects of this intervention. So here we're testing voluntary, not assistive effects. So how he's able to grasp without the stimulation, and then after he does this 4-week intervention, his grasping ability again without the stimulation, and then at follow-up 1 month after the explant of the epidural stimulation. So to do that, we leverage the Toronto Rehab hand function test, and these are the improvements that we were able to see. So in this individual, we were able to deliver 19 sessions over 4 weeks, and we were able to use some of the control data that was previously sort of published and established using 40 sessions of conventional activity-based therapy only, so no electrical stimulation, over 16 weeks. And what we were able to show is that we can get larger improvements in the motor function compared to the just activity-based therapy. And in fact, we were able to do that. We were able to, I guess, half the number of sessions in a quarter of the time. So we were able to deliver that more efficiently and effectively. Similarly, this is the second part of the Toronto Rehab Hand Function Test, which doesn't actually only look at these functional movements, but looks at these weighted blocks. And we were able to sort of get these similar effects. So this is an example of some of the, I guess, improvement in one of the tasks. So before, he's unable to generate this, I guess, sufficient force to grasp the object. Whereas after, you will see, I sped these videos up because of time. He has slightly more force to grasp the object, which allows him to pick it up and maneuver it, which results in a better, I guess, functional improvement. So here he was able to grasp it, hold it, and then even briefly lift his hand. Now keep in mind this is an individual C4, C5, Asia A injury, chronic, I think 12 years after injury. And then in month follow-up, we were able to sort of retain some of these improvements. So he's able to grasp, pick up the object, and maneuver it. Okay. We also tested neuromuscular coordination to see how this reflects both in the activity of the muscle or the neuromuscular coordination strategies, as well as how this is reflected in these like function or I guess task-driven sort of reaching maneuvers. And what we were able to see is that following the intervention, this is post intervention after 4 weeks, he was able to essentially these velocity peaks indicated that the movements were smoother compared to how they were before. So that also is indicative of the improvements. Importantly, going back to our corticospinal circuits, we tested the corticospinal sort of excitability before the intervention, after the intervention, and the follow-up. And what we were able to see is that these corticospinal circuits were considerably potentiated after the 1 month of therapy, which is sort of correlated to these functional improvements. However, like in the follow-ups following explantation, the corticospinal facilitation begins to wash out, which is sort of consistent with the functional gains as well. So again, this kind of gives us an idea that this brain-controlled neuromodulation approach can be efficient in driving both neuroplastic changes and improving functional recovery. But we wanted to really have another look to understand and to make sure that in this individual, this would not be, or I guess what the added benefits of this closed loop control. So we compared single session results, pre-post corticospinal excitability in this BCI driven, and then we snuck in a couple of the other sessions where we only tested 1 day of tonic, so continuous stimulation. And in the continuous stimulation, single session pre-post assessments, we actually were able to see same results that we saw previously, which sort of indicate that you're not potentiating, and in fact, you might even be inhibiting the corticospinal excitability. Again, this is reaching assistive effects, which are looking at or comparing the no stimulation to tonic stimulation to brain-controlled stimulation. Both are able to have improvements in the reaching, but BCI has this advantage in driving these initial direction sort of angle changes. And what I mean by that is if you look at these force and EMG data of the assistive effects, no stimulation, this individual is unable to generate any EMG activity, which is resulting in almost no force generation in the hand grip task. But when they have tonic stimulation, they can get some force modulation, which is consistent with what's been shown before. However, perhaps initially they get like a much larger boost of stimulation, which allows them to generate this much stronger force in this initial part of the movement. So I'll summarize here. Basically, what this shows us is that BCI engagement goes beyond prosthetic control to elicit these corticospinal facilitation, and that this neuromodulation or BCI controlled neuromodulation can help us synchronize these cortical activations and postsynaptic stimulation to elicit Hebbian-like plasticity, which when combined with activity-based therapies and activity-based practice can be leveraged to improve motor function in an individual, even with a motor complete spinal cord injury. We are doing some work looking at how we can use these same types of approaches for locomotor recovery following spinal cord injury using non-invasive stimulation and things like that. But because of time, I will not be going into that today. So thank you very much. I'm happy to take any questions.
Thank you, Dr. Milicevic. I think we have time for maybe one quick question, if anyone has. Otherwise, I would say you can write your questions in the chat, and I'm sure I'll be happy to respond afterwards. Hope, go ahead.
Hi, Mattia. Just from my background at U of T, I worked with BCI FES and have a background in epidural stim too. So I'm just wondering, my first question is, I may have missed it, but did you use the BCI ES system with anyone with a complete injury? And then I'm wondering, what are your next steps? Where are you going from here?
Yeah. So we were okay. So this one sort of first in human kind of case study that I showed, this was an individual with a motor complete Asia A injury, and that's why I guess they were more, suitable for this more implanted approach. Most of the work that we're actually doing in the lab, especially with the non-invasive stimulation, is more geared towards individuals with incomplete injuries, with more sort of spared tracts that we can, again, try to potentiate through this sort of neuroplasticity eliciting protocol. And what we've sort of been seeing is that we can drive better facilitation in individuals with more sort of discomplete or incomplete injuries. But nonetheless, again, with an implanted approach below the level of injury, we can still get some even carryover as well as assistive effects in somebody with a complete injury.
Thanks very much. I'll pass it over to, oh, we've got one more quick one from Vivian. Vivian, you're muted.
I know it's as quick as me finding the mouse on like the two screens that I have over here. My apologies. Mattia, great work. I really was very pleased to hear all the fabulous developments. My question is a little bit actually trivial, but I was curious what happened when you changed the anode from being on the front of the neck and down to where the iliac crests are.
Great question. And I think we haven't done the most sort of up until recently, so overall iliac crest return, anterior neck return electrode does elicit, most post-activation depression. However, it's not really suitable for continuous stimulation because you get like co-contractions of the muscles. So in the study that I presented, we leveraged iliac crest, and we really kind of took the time to make sure that we're getting these post-activation depressions. But recently, with a colleague in Germany, we sort of did like an updated computational simulation where we compared more systematically different return electrode configurations, including anterior neck, iliac crest, even clavicles, which indicates that with the return electrodes on the iliac crest, you get predominantly motor activations, so that they're not necessarily most optimal, whereas anterior neck gets very good activations, maybe not very feasible, but some sort of mid-ground, most feasible approach is the clavicles.
Very interesting.
We just took this, or we just posted this on a preprint, so happy to share it. Which hopefully gives some insights on I guess
Wow.
You know,
That would be quite fabulous, Mattia, and it could change some of the things that we do. If you could share that, that would be amazing.
I definitely will. Thank you so much for the question, and I'll share it after the talk.
Thanks very much, Vivian, for the question, and Dr. Milicevic for the wonderful talk. If anyone has any other questions, feel free to type it in the chat, and I'm sure he'll be able to respond after. But I'll pass it over to Hope to introduce our next speakers.
Hey, hi everyone. First, we have our two student presentations, and we have Dr. Damien Manzone. He is a postdoctoral researcher at Kite Toronto Rehab Institute and University Health Network, and I'll let you take it away.
Share my screen. Thanks. Production. Okay. So hi everyone. Thanks for giving me the opportunity to speak. I'll be talking about developing and assessing augmented reality rehab applications for individuals with cervical spinal cord injury. I'll also get a laser pointer going as well. Okay, so the main motivation for this work is the need for high doses of high quality home-based upper limb rehab. And when I talk about this problem, I usually like to look at how long people are essentially staying in spinal cord rehab after an injury in Canada, which is what this study is showing. And it's essentially showing that after a spinal cord injury in Canada, individuals are staying for just over about 3 months. And there's obviously a lot of variability, but the point here is that people are getting sent home when there's still a lot of room and potential for neurorecovery. So that means we have to think about ways that they could continue doing rehab at home for continued recovery. But when we think about home-based rehab, we also know there's a lot of limitations there. So when someone goes home and they're trying to do rehab at home, there's often little guidance. There's not much feedback about the movements, their exercise they're doing. This might result in low motivation and low compliance overall. So we're thinking about building these tools for home-based rehab. We also want to think about ways we can promote neuroplasticity. So obviously, based on the meeting we're having today, it's pretty obvious that activity-based therapy and the principles of activity-based therapy needs to be prioritized, and also thinking about ways of how we could include some neuromodulation-based therapy as well. And with this case, I'm showing an example of FES. So thinking about this and very specifically relating to activity-based therapy, we think that augmented reality can actually provide a potential solution. So augmented reality here is when we're actually giving people extra cues while they interact with real objects in the real environment, so augmenting their reality. And if we look at how that relates to the principles of activity-based therapy, we see that if someone's interacting with real object, that means they're going to have some weight-bearing activities. It's very task-specific, so it can be very similar to an activity of daily living. And we can also incorporate different forms of visual, verbal, and tactile feedback that match what they're doing. So with AR, what I'm saying is that we can actually afford some task and sensory motor specificity. The purpose of this study, and there's actually multiple studies here, was to develop augmented reality systems to track hand posture, provide guidance, and provide augmented feedback directly to the user, which is one system, and also support a closed-loop FES system, so it's another system. And at this stage, we wanted to assess the feasibility and meaningfulness of these systems in the context of home-based rehab. Okay, and for simplicity, when I'm talking about the AR system alone, it's just going to be a picture of a headset, and when I'm talking about the AR plus FES system, you'll see the symbol somewhere on the slide. So in terms of the people that participated in our study, we had individuals with cervical spinal cord injury from level C3 to C7, and also across the AIS ranges from A to D. We also had a large range of ages as well, with fewer females, but mostly males, but like I said, a large range of ages. What I'm showing here in the middle is just the level of hand impairment that these individuals had. So each row of this heat map represents one participant, and then each column represents a different category on the GRASS scale. So tiles that are more blue means a higher score, and tiles that are more orange mean lower score. So the point of this is to get a general overview that there's a large variability or large range of the hand functions, with some participants being higher hand functions and some lower hand functions. What we did is we had individuals come in to a clinic. We did a clinical assessment. They tried the AR system, so not in a home environment at all, but they tried the AR system here for about 30 minutes. And then we did questionnaires and semi-structured interviews to assess feasibility and meaningfulness. So the first system here, I'm just going to show screenshots of the system, but if you want a full demo, you can look at this QR code and it'll take you to a YouTube video. But the first system, we want to provide guidance and augmented feedback directly to the user. Okay, so user is wearing this augmented reality headset, and this is what they're going to see in their environment. Okay, so they still see their whole environment, but what we added is a first prompt saying, what object do you want to pick up? And we have the system set up so they can pick up a marble, block, or credit card, so some different grasping. Then what they get is some object-specific guidance. So here on this target posture screen, they get different versions of how we think, or like an optimal grasping pattern. So we'll say grasp the object between all of your fingers, so kind of like a power grasp, and also a way for them to track the repetitions. Then they would pick up the object, and we have some automatic hand tracking on the headset. And we see they're using more of a tip pinch than a power grasp. They can save that posture. And on the feedback screen at the end, we're actually comparing what they did to the target posture. We see a number of different ways we're comparing that. We have an overall score of 100, which is an overall matching score. So higher scores are better, and it's also color-coded. And then also we have different representations of what they did versus what the target posture was. In another system, we included FES here, so we want to provide guidance like we did before, but also inform a closed loop FES protocol. So now someone's wearing the mixed reality headset, or the HoloLens 2 in this case, and then we also see that they're hooked up to an FES machine. We see you have electrodes here on the forearm, or the finger extensors, the finger flexors, and also the thumb adductors as well. And here we were calculating error from when they were picking up that object, and now the error was getting sent to the FES. And the idea with this closed loop system was that higher error leads to higher stimulation amplitudes. So you take a quick look there. This is their perspective. This is a perspective of the outside looking in, like a third person perspective. And this is what the stimulator output would be. So if they're still getting this guidance on the left, but if someone's picking up the block again with a tip pinch and not using their whole hand, we have a relatively high FES amplitude. And then once the FES kicks in, it starts contracting their hand or helping them perform the movement, and the FES amplitude decreases. So the FES is always on within a range, but the level of the FES changes in a closed loop fashion. And they're also doing this independently using their voice. So the therapist is not actually triggering any of the FES for them. So let's look at the perception of these systems. So first we can look at the AR system. So here I'll show you that individuals, for the most part, agreed and strongly agreed with the statements that it would improve their compliance with their treatment plans, increase their motivation. The repetition counting was helpful. The feedback helped them focus on their movements, and it can provide useful feedback and rehab exercises at home. Okay, and then from a thematic analysis, we can pull out some themes. So I'll read some quotes from this. So it talks about removing some rehab barriers. So an individual saying, it's not super motivating to come in as an outpatient for an hour. So if you get the same kind of feedback early on, it would be useful. They talked about the quality of the guidance and feedback, saying they were trying to adjust their movements so they could tell where they're making mistakes. And also that the score was very motivating, like they were playing a video game. If you look at the AR and FES system, the questions were slightly different because now we have the inclusion of stimulation. So again, most of the participants agreed or strongly agreed that it could help them produce the correct postures. It can make a difference in their recovery. It addresses some limitations for other at-home rehab. And they would like to use the technology at home, and they think they would be able to use it without therapist supervision. Okay, so here they're highlighting the potential for recovery, speed up the process of the nerves coming back. One barrier they bring up is that they think there's a lot more components here, so they need additional training, saying there's a lot of different aspects that someone needs to help you with, specifically talking about the electrode placements, maybe putting them into a garment. But they also talked about the idea of being independent was their goal, and this can help them be independent. So overall, we see that these systems have a potential for increased dosage of at-home rehab, but it's important to note this is the first step in a staged approach. So in this study led by Crystal Musselman, they talked about using the staged approach when we're developing new technologies to help with future implementation, and we're assessing feasibility, appropriateness, meaningfulness, efficacy, and economic evidence. So where we are now is really in these uncontrolled or controlled trials. So really it's at early stages. And the future for the headset would be testing this in a home environment with that AR application, and then with the AR and FES application, testing it across multiple sessions, not at home just yet, but more to look at safety and independence. and also knowing that we're going through stages of iterative development so that individuals with spinal cord injury or cervical spinal cord injury can help make meaningful changes to the applications. So thanks everyone. I just want to acknowledge the funding body, the Craig H. Nielsen Foundation.
Thanks, Damien. That was really interesting. You can see the trajectory to using that virtual reality and translating it to home next for testing. We do have a minute for questions if anyone would like to ask Damien a question. Oh, go ahead, Vivian.
Yeah, just a quick question. This is fabulous. Thanks for presenting that, Damien. And and the idea of being able to not just do rehab at home, in my opinion, but have that continuation process after discharge from hospital and continuing the rehab at home is very important. So how fast? I know that you're looking at you're planning on doing home feasibility, but how fast is it right now to set up the system?
So the headset on its own system, like they just put it on and it'd be like an application. So when we had people, have to be training for people to use like these headsets because like a computer on your head. But right now at this stage, we had people come in, we put it on their head and we just started the application for them. So it's just putting on their head and starting it. So that one's actually very low fidelity in terms of setup. The FES one, this is why I said we can't really send people home with this yet. Because first of all, the device can't go home. There's a lot more engineering involved. So that, like, you have to put on the electrodes, you have to set up the actual FES stimulator, and there's also a computer in the loop as well. So that's more, I think, for the future, a lot more engineering kind of solutions there, where they put on, if they could know where to put on the electrodes and then put on the headset, the communication would be a lot easier and a lot faster. So that's why in terms of that, because that one took probably like 10 minutes, say, to set up, 5-10 minutes to set up, but then finding the right electrode placement, that's a variable across people. So it depends on who we had, but of course we also want to see if people can do that independently over time. So the first session is probably going to take the longest, but if they keep coming back, they know the placements, they know how to hook things up to a certain extent, can people get more independent? So they're relatively quick to set up, but it depends on what participant you have and how hard it is to find those optimal spots for FES.
And they have to be the perfect spot. I guess is there leeway? For example, can we develop like, because we're developing wearables that would incorporate all those types of electrodes and and technologies, and the wiring is already within the clothing and what have you. Can they just put it on? And does it have to be super exact? Because if it does have to be super exact, then you could just build more electrodes in the garment and just do a quick artificial intelligence type of approach to choose the best outcome automatically without someone else coming to assist, I guess.
Yeah, that's some people brought this up, probably not knowing that I think you're doing this work. Obviously, Milos Pavlovic is doing some of this work as well. And someone suggested that, what if we put these in garments and maybe you fit me to a garment once or has multiple locations and I just pick them, and it's kind of as easy as that. So people did say there probably is easier solutions. So I do think in the future, this could be something that's very easy to get. And it won't have to, even if you needed more kind of exact electrode placement, you can have that. You just build it into the garments, for example. So people did say, if I had something like that, this part would be like the biggest barrier was that. So if I just got past that barrier, it'd probably be pretty easy. So I do agree with what you're saying.
Great. Thank you so much.
Thanks, Bean.
Thank you so much, Damien. There is a question in the chat, so I'd ask you if you'd like to answer it there, please. And yeah, that was a great presentation, and I would like to introduce our next guest.
Thank you.
So welcome Dr. Sujata Sinha. She's a MITAC Accelerate postdoctoral fellow at Institut Universitaire sur la réadaptation et déficience physique de Montréal, Centre de recherche interdisciplinaire en réadaptation du Montréal métropolitain, CIUSSS, Faculty of Medicine, Université de Montréal. Welcome, Sujata.
Thank you, Dr. Hope. Let me share my screen. Okay. Right. Hi, everyone. A very good afternoon. I'm Sujata. I'm a postdoctoral fellow in Dr. Bartolome's lab, and today I'm going to present a work on feasibility of combined activity-based therapy and transcutaneous spinal cord stimulation for upper limb rehabilitation in spinal cord injury at subacute stage. So to better understand why this question is important, let's look at a brief background first. So we know that cervical spinal cord injuries significantly affect sensory, motor, and autonomic functions, limiting essential tasks in daily life. In fact, a 2022 Canadian report stated that over 86,000 Canadians live with SCI, including traumatic and non-traumatic cases, and the number is expected to only rise over the years. Hence, effective rehabilitation is essential to address various challenges this population is facing. The good news is that we already have a traditional approach of rehabilitation, which is activity-based therapy, commonly known as ABT, which includes intensive, repetitive, task-specific training that promotes neuroplasticity and supports functional and health improvements. However, ABT indirectly targets the nervous system. On the other hand, a relatively more modern approach or technique, which is transcutaneous spinal cord stimulation or TSCS, directly modulates neural activity by increasing the excitability in the sensory pathways and hence enhancing the motor output. So given this complementary mechanism, several studies have looked at the efficacy, usefulness of TSCS, and let's look at them. So those studies have shown how TSCS can bring in restoration of upper limb strength, sensations, and motor functions. And TSCS has also demonstrated neuroplasticity effects. Not only this, there are also several studies that have combined this activity-based therapy and TSCS in chronic SCI patients that have shown encouraging results. However, whether this combined effects can be seen at the subacute stage is not clear yet. There is no clear evidence if there can be a correlation between the clinical and neurophysiological outcomes because of this combination. So this eventually led us to our hypothesis of our project that this combination of ABT plus TSCS can boost the improvements in sensory motor functions of the upper limb more than applying ABT alone in spinal cord injury at the subacute stage. So our primary aim was to determine if this combo is feasible for upper limb recovery in cervical SCI patients in an inpatient rehabilitation setting. The secondary aim was to determine whether this combo yields a greater improvement in the motor outcomes compared to ABT alone. And we also wanted to explore if this combined training induces larger neuroplastic changes within corticospinal and somatosensory pathways through which we measured using TMS and SSAPs. So what we did in our experiment, we first recruited inpatient participants according to certain inclusion and exclusion criteria. They underwent baseline assessment at T1, and then they were randomized either into sham group or the intervention group. Then all these participants participated in the training sessions, which were 20 training sessions with 45 activity-based therapy. And then they also underwent post-training assessments at T2 time point. Now, as for the training sessions that included activity-based therapy, these were cardiovascular warm-up, mental imagery, upper limb strength training, stretching, and weight bearing. And as you can see on the right-hand side figures, the participant is doing some activity-based therapy and at the same time is receiving some stimulation on the cervical sides, C4 to T1. Now, the difference is that the sham participants, they received this intensity, the stimulation, just at a perceptive intensity, whereas the intervention group participants received stimulation at an intensity that was enough to facilitate their voluntary movements. As for the assessments, we had two types of assessments. First is the clinical one, which took about 90 minutes. So we measured the primary outcomes, upper extremity motor score, which was used for measuring the upper limb strength. The secondary outcomes included monofilament, proprioception, grasp, and release test. The second type of assessment, which was neurophysiological, for this we measured motor evoked potentials from transcranial magnetic stimulation TMS data and somatosensory evoked potentials from EEG data. What we found, so we looked at the feasibility study. So far we recruited 10 participants, and about 90% of these they retained to post-training, and one dropped out due to some medical conditions. All these participants completed an average of 89% of the training sessions out of total 20, and they all reported high satisfaction with this ABT and TSCS combination. In one participant, we saw some minor events such as skin redness and hand swelling, but there were no serious adverse effects observed. All right. So now, what did we find when we looked at our secondary aim? What did we find when we looked at the strength of the upper limbs? Well, so first I'd like to say the blue ones represent the sham participants and the orange ones represent the intervention. So as we can clearly see on the left-hand side figure that the score, UEMS scores have increased from T1 from the baseline to T2, which is the post-training assessment in both the groups. However, the increase was significantly higher in case of the intervention group, which you can see on the right-hand side figure. Similarly, when you look at the monofilament test, which was used for testing the ability of the participants to sense, we saw that, so for this monofilament test, lower the scores, better is the performance, and we saw this in case of intervention group where they had very low scores at T2 as compared to T1, which also reflected better performance. As for the proprioception test, which was used for measuring the ability for proprioception, we also saw a significant increase from T1 to T2 in the intervention group. However, for the grasp and release test, we saw that the participants in both the groups, they showed increase from T1 to T2. However, the increase from T1 to T2, the mean difference was not as expected in case of intervention group. And why it is so, it might be because the grasp and release test was not an effective tool to capture the changes. So we are taking this result as an account to incorporate changes before we start our RCT. All right. So from this feasibility study, the results suggest that delivering this ABT and TSS combination is feasible in a subacute clinical setting, and this preliminary MEP as well as SSCP results reflect the feasibility of these electrophysiological approaches for capturing neuroplastic changes, and this preliminary results will also definitely contribute to the design of the RCT that we're going to do soon. Now, interestingly, the project that we are doing is one of the first projects combining ABT and TSCS for upper limb recovery at the subacute stage in Quebec province in Canada. Last but not the least, I'd like to acknowledge all the team members of this upper limb project, without whom this project would not have been successful. And I would like to invite all our audience to follow our updates by scanning our QR code. Thank you.
Thank you, Sujata. We are a little bit behind time right now, so I'm going to ask you, if you do have a question for Sujata, if you could please type that into the chat. Thank you so much. And I'm just gonna, introduce our next guests. One moment here.
It's just us, Hope.
Okay. I can still introduce you.
Okay.
Okay, so I'll just read this quickly. Dr. Krista Musselman is a physical therapist, senior scientist with the Neural Engineering and Therapeutics team at KITE, Toronto Rehab, Lyndhurst, and Canada Research Chair Tier 2 in Multimorbidity and Complex Rehabilitation. She is academic lead of the Canadian SCI Walking Measures Group and an executive board member of the International FES Society and the co-founder of the Canadian ABT Community of Practice. And then we also have Dr. Anita Kaiser, who is a scientific associate at Kite Research Institute and the vice president of NASCIC. Her fields of interest are in spinal cord injury and activity-based therapy. Anita's been living with the SCI for 30 years and brings that passion and interest to her work and collaborations with other scientists by exploring ways to improve function and quality of life, reducing secondary complications and barriers to inclusion and social participation. Welcome, Kristen and Anita. Take it away.
Thanks, Hope. And so I do want to say this is mostly Anita's talk. I'm here just to introduce the concept of intensity, but really it's Anita who's going to be telling you the really interesting stuff that she's been playing around with over the past couple months, looking at the role of intensity in ABT programs. So I think we can advance the slide, please. So I'm sure you hear a lot, especially when we talk about ABT, how important intensity is. And this term can mean many different things. So we can talk about number of movement repetitions, the level of motor challenge, the overall dosage or number of minutes of actual training. But what we want to really focus in on today is more the aerobic intensity or that cardiovascular load when people are participating in ABT. And I'm going to give you just a little intro as to why this aerobic or cardiovascular intensity is quite important. And so we know from the literature the specificity of the training, the overall amount, but also this intensity of our motor practice is really important for increasing motor skill. And there's different ways that we talk about what would be considered a high level of intensity when we think about the physiological system. And so through different studies looking at intensity in people with spinal cord injury, I've just listed on the slide some of the ways that they've defined a high intensity exercise program. So sometimes that's looking at the max heart rate between the ranges of 75 to 100%, or it's obtaining at least a 17 on the Borg rating of perceived exertion. Or sometimes it's looking at the speed of movement and how quickly things are being completed. Or if you're doing strength training, we can also consider the repetition max. And you can advance the slide, please. And so this higher intensity exercise training, I know we're all hearing a lot about, and we're definitely, as whether, from my perspective as a therapist, or if you're somebody participating in ABT, we're definitely hearing that we should be encouraging this higher level of intensity. And there are some benefits for high level intensity exercise compared to lower level intensity exercise. And so I've just mentioned a few of them here on the slide. Things like insulin sensitivity, blood pressure regulation, improving overall maximal oxygen consumption. But the one that I've put in orange is sort of the key one that we want to zero in on when we think about ABT, and that's really promoting that neuroplasticity. So increasing levels of molecules in our system that we know can help promote neuroplasticity. I'm sorry, if you could just advance, there'll be a little, thank you. So that is why we're so interested in this higher intensity aerobic exercise when we're performing ABTs. We want to take advantage of these mechanisms that can help promote that plasticity. And if you're interested in reading a little bit more about that, one study that I quite like, it's a small study done in individuals with motor incomplete spinal cord injury. It's the Leach and Hornby study from 2017. But what they did is they had people walking on a treadmill just in a single session, and it was a graded exercise test on a treadmill where they started at a slower speed, so lower levels of aerobic intensity, and they gradually increased the speed, so they got into that moderate level of exercise intensity and then up to a high level. And as they were going through these different phases, they were collecting blood and then looking at serum levels of BDNF, which is one of those important neurotrophins for promoting neuroplasticity. And the plot that you see on the slide is just showing that change in levels of BDNF D and F throughout that experiment, where you see this big increase when they're at that higher level of exercise intensity. And you don't see that at the other levels of exercise intensity, nor do you see it post-exercise as well. And so with this increasing knowledge of how important aerobic intensity is, if we just move to the next slide, we do now have guidelines. This is just an example of one guideline, and this is specific to locomotor training. And it was put together by colleagues in the US through the Academy of Neurological Physical Therapy. But these guidelines, which are available online, but they really do try to stress that importance of having that high aerobic intensity as part of that package of activity-based therapy that you deliver. So that's a little preface to sort of maybe give some motivation as to what Anita has been doing over the past few months. And Anita, I'll pass it over to you to tell them about what you've been doing.
Can you hear me?
Yeah, now we can.
Okay, great. Yeah, so Kristen and I were curious about whether we could replicate the guideline data for locomotor training into other types of ABT. So we decided to do a mini experiment using myself as a case study. So on screen here, you can just see my profile. I'm a 53-year-old postmenopausal female with a complete tetraplegia injury of 30 years. Prior to this experiment, I was participating in ABT once a week for 3 hours, and I've been doing that since 2013. I did take resting measures of my heart rate and blood pressure because I wanted to track that. And so my resting heart rate averages about 50 to 55 beats per minute. And my resting blood pressure on my final session was 109/73, which is a really good blood pressure because it generally averages between 79 to 95/50 to 70. So just keep this in mind as I go through the study that we did. So the types of activities we were going to be tracking was load bearing and standing, sit to stand transfers, load bearing and high kneeling, and low to high kneel transfers. And I did them specifically in this order because I started with load bearing and standing because it's the activity that requires the most energy. So I wanted to make sure that I had enough energy to do that exercise, and I would only be able to do that first. If I altered it and did it last, I would probably have been gassed out and not been able to do it. So I stuck with this order throughout all the sessions. And my goal was to do 3 sets of each activity with a 3-minute rest in between. I was targeting for that high Borg range of 16 or 17 to 20. And my goal was to track my number of reps or my duration, my heart rate, and my blood pressure. And so the plan was to do a baseline assessment. This is right before the holidays, and then we had a 2-week break. And so starting in the new year, I did 6 weekly sessions. And so, related to what Kristen was saying of trying to hit that high aerobic capacity, my goal was really to do as many reps as I could, as fast as I could, for as long as I could. So when we look at standing, and you can see in the video here, I'm able to get up into standing and stand independently with out trunk support. The belt is just loose on my hips. But you can see as I start to fatigue, I start to compensate by twisting a bit, leaning back with my head and my upper body. And I will continue to do that until I basically reach muscle fatigue and I drop back down. So my baseline stand was 29 seconds, and I'm just reporting the best of the 3 sets. And over the 6 weeks, I ranged between 45 seconds to 1:40. That 1:40 peak was at week 3, but that included a lot of compensation. And so I shifted gears over the last 3 weeks to really focus on trying to maintain good form and duration. And so it was nice to see that, from baseline, I was still able to improve while maintaining good form. You can see my heart rate went up quite a bit over baseline and my blood pressure dropped a bit, but I did reach that target, and you could see when I dropped from fatigue. When I look at sit to stands, again, I was doing these independently. However, I had assistance right near the top where she would hold the belt tight so I could lean against to pull the hips in. My baseline was 14 reps, And over the 6 weeks, I ranged between 12 to 17 reps. You can see it fluctuated a bit, but from week 3, there was a steady incline. Again, my heart rate was quite above my baseline, which was nice to see. And I did reach my target, which was great. And I'm going to speed this up. There was a bit of fluctuations. Again, I think that's a reflection of, what my blood pressure was starting out that day. I also started to get muscle strain in my wrists and elbows, and that impacted my performance in some of the exercises over time. And then you can see where I have fatigued out there. So high kneel, you can see I have really good form. Sorry, the video stopped, so you won't be able to see when I drop down. But my baseline score was 1:30. Over the week, it fluctuated between 60 seconds to 2 minutes and 30 seconds. And you can see there's a lot of variability here. I did maintain a high heart rate, which was great. However, this was the activity where I feel I did not reach that target Borg and muscle failure, and that was really predominantly due to blood pressure. I recorded my blood pressure pre-kneeling, which was 97/74 on my last session. And you can see post-kneel was 69/54, and that was after a 3-minute rest. So it really dropped significantly. And then at 3 minutes, it really wasn't enough to recover to be able to stay up for a long time for the next 2 sets. So this was really my limiting factor for this exercise. So the final one was low to high kneel transfers. I was able to do these independently. My baseline was 16 reps, and I ranged between 14 to 24 reps. So again, a lot of variability here. And again, this is where I think that muscle strain in the elbows and wrists impacted performance. But I did get a couple of nice high peaks above baseline. My heart rate was also up as well. I did reach my target. Blood pressure dropped, but it was interesting. I feel like blood pressure was a lot better with these transfer exercises where there was movement involved, much harder to maintain when it was just the load bearing and standing and high kneeling. And I'll speed this up so you can see when I fatigue out. See, it starts to get slower and harder to pull in the hips and the trunk, which is below level injury. And then that's the last one. Yeah. So in summary, I feel like this little mini exercise was a success because we were able to achieve a high aerobic intensity of over all 4 exercises, which is really nice to see. Especially I was surprised with the 2 load bearing and standing and high kneeling because I didn't feel that same, I reached a high Borg, but I didn't get that same cardio feeling as I would if I was doing like an arm ergometer or even like these sit to stand transfers. So I was surprised to see that I did actually reach a high aerobic output. Keeping in mind it was only 6 sessions, so you can take the results with a grain of salt. You can also see that there's a lot of factors that affect performance from day to day. So blood pressure was definitely a big issue. If I started out with low blood pressure right from the beginning, it really impacted the other exercises going forward. The repetitive strain injuries were also affecting. And I also feel like menopause was a factor, which we really don't know much about, but I can definitely see a difference now compared to pre-menopause in my performance, my susceptibility to injury, recovery from injury, and change in function and improvements over time. So I'd love to see more research done in this area. It was nice to see that my compensation decreased, especially with the load bearing and standing. So I was able to improve form and duration over time. And for all the activities, I did improve over baseline in at least some of the sessions, although it was not necessarily linear. So in terms of my reflections after this, I think one of the things I'm really thinking about was that high aerobic intensity that I obtained for a long enough duration to improve performance. So compared to locomotor training, where I think people are generally doing it for about 45 to 60 minutes for a session, really each set was only about a couple of minutes. So was that long enough? And if not, how do we find that balance between reaching muscle fatigue and failure with, prolonging aerobic intensity in order to improve performance? So I think something we have to really consider. And then also really thinking about these limiting factors. So how do we dose appropriately to really try to reduce these injuries? Because over 1 week was actually not enough time to recover from these repetitive strain injuries. So they ended up becoming a chronic issue that kept building over time. And then, of course, blood pressure was a big limiting factor, which I think would affect a lot of individuals with tetraplegia. So when I thought about what are things that I can do differently, because I still want to sort of play around a bit, and I'd love to hear everyone's opinions. I think in lieu of time, if you have thoughts and opinions, please add it into the chat. But some of the things I was thinking about is, I could look at increasing the number of reps by incorporating some therapist assistance or more therapist assistance for some of those exercises in order for me to be able to increase the duration of that high aerobic intensity. I could also look at increasing the number of sets. So instead of just doing 3 sets of each, maximizing those sets until I reach fatigue for that exercise. I could look at it gradually increasing the intensity in order to hopefully reduce muscle strain. Or actually look at switching to a high intensity interval training. So alternating between load bearing and standing with a sit to stand. So I sort of give some of those muscles a rest between sets. I'd also love to add in transcutaneous spinal cord stimulation to manage blood pressure and see what effect that has on performance. I could also consider adding in FES to my quads and glutes, or adding a supplemental exercise at home that targets the trunk and upper body, which would allow me to do more reps, or, maintain that load bearing and standing and high kneeling for longer. And I just want to acknowledge Walk It Off, my therapist, and the student volunteers that helped me with recording the sessions and tracking the data. And I'll stop sharing. Don't know if I'm going to say we don't have time for questions, but please add your questions into the chat. Chris and I would be happy to answer them, and also any thoughts and opinions on things I could do, because I'm still going to sort of play around with things and see how it goes. But I'd like to introduce our final session for today. It's our panel discussion. And it's titled ABT from Every Angle, Evidence, Expertise, and Experience. I'd like to introduce our 4 panelists. First up, we have Chris Rice, who's been living with a spinal cord injury since 2012 as a quadriplegic. He's a manager of the peer support program with spinal cord injury in Nova Scotia and is also a volunteer fighter in Bridgetown, Nova Scotia. He's co-authored multiple research studies, sits on a national advisory board, developing a national model of care for spinal cord injury, and has designed his own ABT program since moving home to Nova Scotia in 2010. Nancy Morrow is the lead neuro-exercise specialist and co-founder of RIU Paralysis Recovery Center in Edmonton, Alberta. She graduated from the University of Alberta in 2014 with a Bachelor of Science in Kinesiology and has been with RIU since its inception in 2017. Nancy has traveled internationally to pursue specialized training in neurorecovery with foundational education from Project Walk and the Neurorecovery Network, both of which have helped shape the evidence-based standards and therapeutic practices now used at RIU. Her work focuses on applying activity-based therapy principles to promote neuroplasticity and functional recovery in individuals with spinal cord injuries, strokes, and other neurological conditions. Andrew Perot is a senior physical therapist in spinal cord injury rehab program at the Institut de Réadaptation, Gingras, Lindsay de Montréal, and Quebec. She earned a master's degree in educational psychology from McGill University in 2006 and is actively involved in educational initiatives within the rehab center. She serves as a lead clinician in the SEAM research program and has a strong interest in integrating activity-based therapy into her clinical practice. And finally, we have Dr. Sarah Donkers, She's an associate professor in the School of Rehab Science at the University of Saskatchewan, and she previously worked clinically as a neurophysiotherapist for over 10 years across all care contexts. The focus of her research is to better understand how we can optimize functional recovery and brain health through neurorehabilitation, and how we can get such approaches into routine care, bridging neurorehabilitation interventional research with implementation science and health services. So thank you. Welcome our panelists. If you don't mind turning on your cameras, and we can get started with this session. I do have a number of questions I'd like to ask them, but really open to hearing from the rest of you that are joining online. So feel free to chime in, raising your hand or typing in the chat. We can sort of include you into the discussion as well. So if we can take down the slide and just have our panelists join live, that's great. So I want to start first by just acknowledging that ABT isn't a one-size-fits-all type of program. So what does your process look like when customizing programs for your clients who have different types of spinal cord injuries, different goals, and different lived experiences? Maybe we can start with you, Nancy.
Yeah, absolutely. Thanks for having me. It's a pleasure to be here. I've heard some great talks already. And so, yeah, our program is based off of an initial assessment. So we meet you and get a good baseline. And from that baseline, we build the program around kind of that information and knowledge that we get from there. Also including your goals. So why you're coming is super important to us, and it's foundational to driving the motivation behind the recovery. We know that if you're more invested, you're going to see more progress. So really tailoring it around your goals and then building it around that starting point and starting marker, if that makes sense.
Yeah, absolutely. How about you, Andrea? Like, what would yours look like, compared to what Nancy just talked about?
Well, yeah, no, hi everyone. Coming from I'm working in a public government center, the main rehab center in Montreal for spinal cord. And obviously we have a wide range of clients coming to us very early on in the rehab process. So we definitely have to tailor what we can do and how we can introduce ABT in the traditional setting, depending on the medical conditions. Obviously, sometimes hypotension is too much involved, as sometimes the client is just so not ready in terms of endurance or other medical conditions. But then we do have the clients that very quickly we can start the FES bike training sessions. We can start early on standing and the gait training, more high tech ABT. So I think that's the nice thing about ABT. We can go more low tech and start introducing and educating, because I think in the public center, that's a lot of our main role, is to educate and show what type of treatments are out there and what's possible as they go through the rehab and change according to their objectives.
Yeah, that's a great point. I think education really is so important, especially in that beginning stages, just to let people know about what ABT is. Sarah, what are your thoughts?
Yes, similar to Nancy and Andrea, of course, the individualized, meaningful motivation. I would say one thing we try to prioritize where possible is the whole practice of the task-specific training. And so right now, one of our main programs and research projects are in the community center setting. We have lots of adaptive equipment and lots of hands. So we get student trainees and volunteers coming through. So we're definitely privileged in that way. And we also have access to a pool. So I'm just trying to acknowledge, although we're trying to prioritize that whole task practice, we realize we have that privilege of the equipment and extra hands that it sometimes take. But to your point of tailoring, I think, Anita, you pointed out two critical things that influence tailoring in your presentation. It's tolerance, right? So how quickly is someone fatiguing? How are we balancing that challenge and aerobics challenge versus the muscle fatigue? And then it's also keeping in mind the musculoskeletal impairments that can actually be triggered by this type of training. So although we have this like ideal where we'd like to start, we realize we have to sometimes build up capacity and use lots of modifications to really get to that point where we can dive into that tension and training. And we found the pool, again, if accessible, has just been incredible in those building up phases. We've also found some people where we can't start with the task specific or ABT training. We just have to start with more aerobic for about 3 weeks, a couple times per week, to get that loading and build tolerance.
Yeah, good points. And, I think also, motivation is the other factor too, of the individual and how much effort they're willing to put into all of this as well. And, I'm gonna head over to Chris now, who has like the lived experience of ABT. And, I think, Chris, you'll probably speak about this as well, but even just based on that little experiment that I just too, is just keeping in mind that it's also a matter of considering what your health is for that day, how you're feeling. And, like you said, Sarah, like in terms of the injuries and stuff like that. So I think not even just tailoring between individuals, but also tweaking within your own session based on how you're doing that day. And I'm sure, Chris, you can speak to that.
Yeah, especially with the weather shifting so much in Nova Scotia recently. Cold, wet days, especially when it's shifting back and forth, can really wreak havoc on the body and make exercise a bit frustrating. And Sarah, I wish I still had access to a pool on a consistent basis, because it was one of the single biggest things at the beginning that helped me. So thank you, everyone. So my process focuses on 3 things: function, goals, and real world context, as we just spoke about. So I look at what I want to improve in my daily life, what kind of changes need to be made to actually get there, and what risks I need to manage. Safety becomes a huge thing when I'm doing a home program. In my own program, training alone means I have to adapt exercises for safety and practicality. So I prioritize exercises that serve a purpose. I customize around safety and environment. Because I train alone, I can't do certain exercises that require a spotter, like any heavy kneeling work involving balance or stairs. Instead, I adapt with resistance bands, cables, and padded supports. As is typical, spasms always seem to be the strongest when I'm in the worst positions. So, as Anita mentioned earlier, blood pressure is also a main challenge, especially when considering safety, as the time of exertion and remaining in one posture increases. I separate my training into 2 distinct categories. I go traditional strength and cardio work on one day, and then another day will be ABT training. I create a clear separation between those, just because of how I document it and how I find the 2 types require drastically different types of focus and energy. ABT for me is much more psychological, whereas strength and cardio training is obviously just kind of brute force going for it. Elevating my heart rate consistently during exercise remains probably my biggest challenge, and is my current training focus with cardiac endurance. So far, that's mainly been through boxing and wheelchair sprinting, but I'm really striving to try to be able to implement ABT to achieve that.
Yeah, and it's really great to see how you've been able to tailor your home program, to accommodate the fact that you don't have that therapist assistance helping you. So that's really, really neat and interesting. Okay, so the next question I had was that given the evidence that Kristen brought up in our previous talk that demonstrates that high repetition combined with high aerobic intensity leads to the best outcomes, at least when it comes to gait training, what would it take to bring that approach, to our hospitals, our community, or even like with training at home? I don't know who wants to tackle that first.
I can jump in. So, yeah, so I mean, obviously, the research is very clear that the repetition and intensity does help drive the change. We know that, activity dependent neuroplasticity is a foundational basis for what we do. So the gap is not necessarily the knowledge, it's the implementation and the different structures that exist depending on where you're at. So I think there's a lot of barriers within hospitals and within larger systems just because of lack of resources. I think resourcing is a big component to implementing the high intensity. I think there is also the limitation in how the clients present. You're getting them in acute care and in that more injured state, and not as safety is obviously the biggest concern with this type of program as well. So if we're not able to safely do any sort of high aerobic intensity, then that's going to be a limitation within the hospital setting, just from our perspective. We've also, just within local rehab hospitals and talks, is just bringing the staff up to date on ABT principles, understanding what it is that we're doing, and that it can be done safely within those settings. Personally, I've been to a lot of the sites for the Neuro Recovery Network in the US that do have the acute care locomotor training programs, which is a form of activity-based therapy in the hospital setting, so in the rehab hospitals. So it has been done, and I know it can be done, but bringing it here across the borders, I think, is a culture shift from, early discharge to potentially early loading. So it's just a shift of, we're not just getting homeostasis and stability, but we're actually pushing the envelope on progression. So that's just kind of a little bit of the take on hospitals, but helping them understand that the small changes, like the structured high repetition, even if it's just stepping blocks, so increasing by just a little bit within the capacity, even if it's 50% aerobic capacity, can still make a big difference early on and shift outcomes for clients. In the community, I think we are driving a lot of change within our own community. I'll just speak for REU, but we do a lot of high intensity programming, and we see the big difference when we do that programming. So a lot of it's education. I think, like everybody's been saying here in this talk, is educating the clients on what's the most beneficial, giving that recommendation and backing it up with science, which is why we're all here, is the science is driving this forward. So education is going to be that big thing that helps layer in more of that neuroplastic change. And then at home, a continuation of that education, and what can they do by themselves without the extra hands, what's still possible, what's still going to be driving that neuroplasticity forward. Like Chris had mentioned, like the FES bike program, right? There's different things that can still drive that aerobic capacity. So working together, a lot of it's an education base from my perspective of building it and having it in every single setting.
Yeah. So it's kind of a good segue for Andrea to speak about that hospital side that you've already sort of touched on in the barriers there.
No, Nancy really mentioned this. One of our biggest barrier, and it's really a challenge, is to get that high intensity. Yes, it's because the lack of staffing, but I think in the hospital setting, we also have challenges of the specific mandate, length of stay. Our clients, even we're lucky enough to have Dr. Barthelemy and her research team with us, and which we heard before with the SIM project. And we have a huge group of researchers helping us intensify our treatments. But some of our clients are just so busy in the rehab setting. There's bowel and bladder management teachings. Sometimes they're looking for a new apartment. Their priorities or their stressors have to be considered as well. So sometimes, even if we have the human resources, it's really hard to find time within a day for our clients to have the energy to get through all the teachings they need and all the priorities and intensify the treatments. But that is definitely a challenge that we do have in the hospitals. We haven't found all the answers yet. It's definitely, I think in hospitals, and something Nancy touched upon, is the traditional therapies are, like clinicians can be very intimidated by ABT. And really, I think in Montreal, the past 5 years, we've really changed a lot our thinking process and our therapy, even our traditional therapies, but it's step by step. And we don't have the high intensity everywhere, but step by step, we're trying to move forward, and we're happy with our small successes, even if there's still a lot of challenges that we're not meeting.
Yeah. And Chris, how about for you? Like, how do you really try to work in that high repetition, high aerobic intensity into your home program?
Yeah, for me, it's motivational tools. So obviously, music is a big motivator for me. I use a lot of that. Um, that's one of the reasons I'm so excited about that patient-facing ABT tracking tool when it comes down the pipeline, because trying to track an ABT workout using a mobile app or any sort of app developed for tracking exercise, pretty much useless when it comes to recording ABT progress and notes and things like that. Um, I think there needs to be more shared education, simple protocols, and communication pathways between these different elements. Um, we should start treating research as something to apply now, not someday. It's nice to be able to implement some of these things right away so that we can actually, try it out and see if it works. Patients and practitioners need simple tools and protocols to get started. Augmented or virtual reality, group sessions, video guides. These are just a few ideas that could help participants in the community stay motivated and consistent. Program templates would be especially helpful for someone like myself, kind of a guide to go off of, progression plans, stuff like that. Self-competitive approaches, it's a term I'm making up. I don't think it exists, but self-competitive approaches, like something a Fitbit or an Apple Fitness workout would provide, would be amazing, but they're probably a pretty ways off. But for me, it's having a way to actually record the progress that I'm making. If I can't kind of quantify and qualify it, then it takes away from the experience.
Yeah, I agree. Tracking is so important. And I think especially like with the home program, really hard to reach that end target because for me, some people are really good at, exercising to their limits. And I need like that person behind me that's sort of like the drill sergeant of like 3 more, right? So being able to find ways to motivate yourself at home to hit those targets is great and really important. Sarah, I'll let you talk about that. Maybe you can even segue into as we get these new evidence coming, how do we bring them into practice and how do we get everyone from research and hospital and community working together to implement these great novel interventions?
Thanks, Anita. I just want to highlight, most of us are aware, and yes, we're talking about spinal cord injury, but we know this is a challenge across neurological conditions, right? So stroke, MS, brain injury, and spinal cord injury, we're seeing the same challenges. But I think we can actually tap into that, right? Like the shared skill set and the shared learning needs. In Saskatchewan, we've recently done a provincial neural rehab needs assessment to really try to dig into those challenges and opportunities to expand dosage and programming options, especially in the chronic phase. And one thing we're doing is really trying to expose our students at the trainee level to it, right? So if they're coming out during their graduate entry PT, and for us, soon to be OT programs, and they're getting that exposure as part of their training, we're hoping that becomes the norm. We realize sometimes there's still a gap between what they're learning and where they're getting their placements. So having parallel programs to support the practicing healthcare providers. We've learned that we need to tackle turnover. So we've been doing these little, interventions thinking, okay, we've got them on board, but then there's rapid staff turnover sometimes. So having standardized onboarding processes, or as Chris mentioned, more protocols or video repertoires that can actually show and be a resource. If we can tackle clinical skills training, I mean, Nancy was talking about information and education. It's great that we're getting more of that, but that alone is not enough to change practice. So we've been trying to implement more skills-based courses. Like, this is how you actually do it. And I think that has lots of systemic and maybe financial barriers, but partnerships between universities and organizations like this and clinicians can be helpful. And the last thing I'll speak to is mentorship opportunities. So in Saskatchewan specifically, we have 2 large centers, Saskatoon and Regina, and then we have a huge rural geographical spread. And so you might be in a rural setting and get someone with a spinal cord injury once every 7 years. But if that person knows that there's someone to contact in these larger centers and they have that contact information and they feel comfortable in reaching out, And I think that's part of building the skills at the trainee level. We found that made an excellent difference. And we recently had someone in Yorkton in a private practice who had a tertiary case for a person with spinal cord injury. And he's like, I've never seen spinal cord injury, but there's no one else for this person to see. And they reached out to us and we were able to mentor him with one of our specialized therapists. So that was really helpful.
That's great. I'm sorry that we're out of time when we can't get to any more of the questions, but thank you to all of our panelists for this great discussion. I'm going to pass it over to Hope to close things off.
Hi, everyone, again. I would like to thank all of our speakers for dedicating their time and preparing such really amazing talks. We had a great variety. I learned a lot today. Also want to thank our panelists who just spoke. If you do want to talk to anyone, we can certainly pass on information if you have any questions about the panel as well, or for any of the speakers that we have. And again, just wanted to thank all of our attendees. We had many people from all across Canada, again, US, international. And I think Inez mentioned it in the beginning. She was really impressed with the size of our group. So, I mean, we're founded here in Canada. We're Canadians, and we're maybe a smaller country with a smaller population, but definitely very passionate, mighty, and a lot of support for ABT here. So thanks, everyone. And I'm just going to pass it off to Sam, who has a few more remarks and a few housekeeping things for you in the end. Thank you.
Thanks, Hope. And yes, fantastic to see everyone. Thank you for joining the Expo. I know I really enjoyed listening to all of the speakers and the talks. Everyone did a fantastic job. I hope you all enjoyed as well. If you haven't seen me before, my name is Sam. I am the coordinator for the activity-based therapy community of practice. I know firsthand what a fantastic group it is. So if you're interested in learning more, hearing more about ABT related topics, we do invite you to join the group. It's open to everybody. You'll get access to a lot of great resources, including more meetings like this one, newsletters, and other opportunities to sort of connect with the people who are working in ABT. So I'll put the link in the chat here, or you can scan sort of the QR code. And yes, Vivian, we are sending out the recording after the meeting. So probably look out for that early next week. But yes, we do invite everyone to join if you're interested in hearing more. If you did enjoy today's session, I know there's a lot more going on in and around ABT and related topics. So I know the pool came up a lot during the panel. So we just wanted to let you know about this upcoming conference on aquatic therapy. If you're in Toronto or would like to visit the beautiful city, it's taking place April 24th to 26th of this year. Again, I can put a link here in the chat for more information, or again, the QR code there is on the screen. Just the last point before we wrap up, we really do welcome your feedback on these events. Hearing from you really helps us improve the sessions that we put on. So if you have 2 minutes just to complete this anonymous feedback survey, it really helps make sure that we're focusing on topics that are important to you and that you want to hear about. So again, there's a QR code. I know there's, a lot of QR codes, but again, I'll put a link there in the chat if you're able to complete that survey. Again, your responses are completely anonymous, so don't worry, we won't be attaching your name to any of that. And then there is a second survey here. It's separate from the last one, but linked at the end of the evaluation survey. It's being run by Praxis rather than the community of practice. And sorry, I'm not sure if it was mentioned earlier. So sorry if this was missed, but this expo was hosted in part by the Praxis Spinal Cord Institute, who supports the activity-based therapy community of practice. If you're not aware of Praxis, we do a lot of work advancing person-centered spinal cord injury research and care, including a focus on neuromodulation and activity-based therapy, as well as innovation. So this survey is about equity, diversity, and inclusion. It's part of our commitment to understanding you as our unique community. So if you have 5 additional minutes after completing the feedback for the event itself, this survey also really helps us understand our network and better serve our network. With that, I will wrap up. I will just say thank you very much for joining today. Thank you again to our fantastic speakers, and I hope everyone has a wonderful weekend ahead.